all the patients for which I'll be using the slides or photographs of them during my presentation. Okay, what is platelet-rich plasma? We all know it is a promising option to treat skin condition due to high concentration of growth factors. As the beautiful part of this PRP is that this is in a small volume. After centrifuge, we get 3 to 7 times more of this growth factor, which is applicable in more of the dermatological conditions. And it has been successfully treated and been seen lots of papers in the literature related to trichology, especially androgenic alopecia. But there are very few evidences, which has been also shown as applicable in dermatological conditions like ulcers, like wound, like melasma, like acne, rejuvenation, etc. But we have thought of exploring in other dermatological diseases, which is also useful. So we are using this Remy Medi Plus centrifuge machine, and you can see this. We have drawn the blood from the patients and centrifuge. This is from the first spin, which is also known as soft spin, and this is from the second spin. There are many things in the literature as RCF and RPF. So this is usually in the RPF, and there is an online also to change the RCF to RPF. And I have tried to find any recommendation consensus in the literature, but I could only find that is IDVL task force recommendations, which usually shows the method to use it. That is 100 to 300 G for 7 to 10 minutes, and 400 to 700 G for 10 to 17 minutes. So others are usually individualized throughout, which is shown in the literature. And beauty of this is that this is the upper 1/3 is the 2/3 is the usually the platelet for plasma. But I usually don't throw this, and when using in the mostly AGA patients with using of the dermapen, that is microneedling, this is very useful, and we have seen very good result with these patients, more than 200-300 patients. So this is a case 1. You can see over here a patient of 70-year-old female who presented with complaint of itching and pain in the vulva, and we can see multiple erythematous plaque which is involving the vulva, especially the vestibule. It was mild on tenderness. Can anyone clinically suspect which disease it can be? Okay. So we did a biopsy. So where we can see these blue arrows, which are usually shown as a plasma cell, and even the red arrows which shows the hemosiderin-laden macrophages admixed with little bit of lymphocytes, which is consistent with June's vulvitis or plasma cell vulvitis. So we treated as per literature, that is topical steroid and immunomodulators, but patient didn't improve. So we tried few sessions of cryotherapy, but also with mild improvement. So we thought of using PRP. So every twice weekly, and patient had tremendous improvement, not only subjectively but objectively also. You can see over here the improvement after second. See, the erythema has decreased, and also the symptoms has decreased. So etiology of plasma cell vulvulitis is usually unknown, though it says as to be autoimmune. Other factors like hormonal, even irritants has been implicated, but due to the rarity of conditions, there usually plan of treatment has been always been limited. But in the literature, surgical, even hormonal therapy, lasers has also been tried, but little fruitful. So, and symptoms I have already told, so will not go to because of shortage of time more. And so in our patients also clinically it has been seen in the literature that this is a cayenne pepper-like appearance. That means hot chili pepper-like appearance, and also patients we have seen it with erythematous macules, which is also seen in our patient. And it has been seen that mostly it has been reconsultant as we told you, but PRP, which is very good, which has lots of growth factors, not only platelet derived growth factors, it has many other growth factors like endothelial like growth factors, vascular growth factors, more drivers, which is very useful and for these patients, and it has been shown that these growth factors inhibit NF-κB and suppresses pro-inflammatory cytokines like COX-2 and chemokines receptors like CR4, thus they are reducing the inflammation. During the literature search, we have only found one case report in this literature. This has been in the literature, only one case report by Suarez et al., who has tried PRP and had been helpful. And this is our second case which we have published in the literature. These are the only two cases in the literature we have found. Second case, a patient, 40-year-old, complained of pain, itching, burning sensation with fusion of labia and the clitoris, you can see, with few areas of ulceration and whitish plug over here we can see. And patient has been treated outside many years but without any improvement. And we did a biopsy. It was shown vulval lichen eruption which was consistent with vulval lichen planus. So we started the treatment with steroid immunomodulators and placental extract. And flaring of the symptoms was always there, so we thought of using PRP on monthly basis. On the third PRP session, she had very marked improvement. I have the slides, I'll show you. You can see over the first one and the second one. The fusion is removed over here. We can see little bit healing of this ulcer also. Even the white plug is also being little bit improved over here as compared to here. And this is the third one. You can see marked improvement in the ulcer. It is healing and there is disappearance of the white plug and the fusion is also disappeared. We have tried to find use of PRP in vulval lichen planus, but we could not find anyone. But only it has been literature, it has been shown that oral lichen planus with PRP is very useful, but not, and we didn't find anyone. To our knowledge, our patient is the only one, as I have shown you and discussed during my presentation. This is the first case of it. So case 3, a 30-old female presented with clinical diagnosis of vitiligo for 10 years and which was stable for 6 years. And she was treated with various centers with topical medicines, phototherapy and with minimal improvement. So we thought of trying mini punch grafting with PRP. We can see over here, this is after post 1 week of mini punch grafting, you can see. This is after PRP. We can see the repigmentations with the grafts, but also cobblestone appearance. But after the third PRP, we can see very good improvement in the pigmentations and also the cobblestone has disappeared. So it has been proposed that PRP usually activates this WNT-B-catenin signal pathway, which helps in melanocyte transfer and stimulate the paracrine pathway, which with the help of fibroblast and keratinocytes usually tries to stabilize the melanocytes and has an anti-inflammatory effects too. So in vitiligo also there is very limited study showing PRP, but we have seen in the literature few studies have quoted that using PRP has the result of early repigmentations, which I will be showing you, and we have thought that because cobblestoning was also reduced due to the use of PRP. And this is one by Salim et al. Who have found improvement with PRP, early repigmentation. So my take-home message is PRP has tremendous potential in the field of therapeutic dermatology. PRP is very easy to prepare and has very minimal side effects, only pain during the injection site, and it is a constantly evolving and larger clinical trials and studies are necessary to explore its application in dermatology. So that this is my last slide. And I welcome all you to Nepal to visit Pashupatinath, place of Lord Shiva. This is Muktinath, place of Lord Vishnu, and this is the place of birth, Lord Buddha Lumbini. And this is a Himalayan range I have clicked from Kathmandu itself, a beautiful Himalayan range. So thank you all of you for being a kind audience. Thank you so much.
Now the next speaker is Dr. Swetha. She is an associate professor. She is an associate professor and she is heading the department at AIIMS Patna. I would call her to the stage to talk on the scar revision. Dr. Swetha, please.
Good afternoon. So I'll be speaking about scar revision by the dermatologist. So what are the tips? What is scar? Scar is the body's natural way of healing and replacing lost or damaged skin. It is usually comprised of fibrous tissue. Scars may be formed because of many reasons, including as a result of infections, surgery, injuries, or any inflammation of the tissue. So the scars are mostly classified into 4 types, that is contracted, hypertrophic, keloidal and atrophic. Apart from pain and discomfort and itching, they cause a lot of psychological trauma to the patients. Hence, they need to be treated. So my presentation here will be focused on the scar revision. So scar revision is a surgical procedure to optimize the appearance of the scar and convert it to an ideal scar. So an ideal scar is thin, flat, has a good color match to the surrounding skin and is oriented along the relaxed skin tension line. You can see the RSTL lines in the photograph. So our scar revision should focus on so that the scar is oriented along the RSTL line. So there are limitations imposed by the shape and size of the scar, differing facial landmarks and the variabilities of healing. So counseling is important to emphasize that the procedure is designed to trade a poor scar to a better scar. It is not to make the scar invisible. So the principles and goal of scar revision. The concept of scar revision is irregular line is less visible than a straight line. So which is facially advantageous when the scar is not oriented along the RSTL. So by scar revision, make the scar narrower, smooth out an irregular scar, improve the color of the scar, correct the facial landmark distortion. So I will be focusing on major two types of scar revision in my presentation, that is Z-plasty and W-plasty. So Z-plasty is to reorient a scar so that the new scar line is in a more favorable position with respect to. So the double transposition of the flap is done here, where the scar is to be excised and lies along the central limb of the Z-plasty with 2 peripheral limbs of equal length placed parallel to each other. You can see in the photograph. Central limb will appear perpendicular to the original scar. With classic Z-plasty, each limb is the same length and angles of the 2 triangular flaps are mostly 60 degrees. So indications of the Z-plasty is scars greater than 30 degrees of the RSTL, contracted scars. So it is helps in scar elongation. and scars that form waves. So there are 4 types of Z-plasty, that is planimetric, compound Z-plasty, unequal triangle Z-plasty or half Z-plasty. So advantages of Z-plasty is reorientation of the scar, as I said, lengthening of the scar, irregularization of the longer scars, and minimal to no excision of the normal tissue is the most advantage of the Z-plasty. Here you can see there is a contracture of the finger. So because of that there is a bone scar of the patient. So I am creating the Z, that is a perpendicular line, and other two the other two peripheral limbs of the scar. You can see the flap is being excised. There will be 2 flaps, and there will be just transpositioning of the 2 flaps in the Z-plasty. So this is the patient in which we did a Z-plasty. This is the baseline photograph, and this is after 2 weeks. So this is another patient post-burn contracture. You can see there is a very bad scar. The patient was unable to flex laterally move her neck completely because of this contraction. So we did a Z-plasty. You can see. So there are 2 flaps. The transposition of the flap with the Z-plasty. You can see now the patient is able to move it. The scar is totally gone, and the elongation of scar, it was the patient's quality of life was improved so much. So this is another patient where Z-plasty was done. You can see. So there is a contracture, and this contracture is totally released by the Z-plasty. So it is contraindications. There is no absolute contraindication, but relative contraindications are keloids and those patients with having hypertrophic scar tendency. Next, coming to W-plasty. W-plasty is designed to make a linear scar irregular. So in contrast to Z-plasty, where the scar is only excised, W-plasty requires excision of the scar along with additional normal adjacent skin. So it is ideal those scars which are against the RSTL line. You can see this patient having a suture mark because of surgery, post surgery. So we did a W-plasty in this patient because this scar is RSTL line. So W-plasty is commonly used for facial cosmetic surgery to camouflage the straight linear scar into a regularly irregular pattern. It consists of excising a series of consecutive small triangles of skin each side of the scar, implicating the resultant triangular flaps producing zigzag effect. It is particularly useful on long, wide, curved, contracted and anti-tensor line scars of forehead, cheek, chin and nose. So the technique is that you have to draw zigzag W's on either side of the scar. So that is the one side is the mirror image of the other side. So the first photograph I saw is a suture mark, this patient. So we created a W, and we are doing either side of the scar, creating a mirror image W, small W's. Then we can excise each of the W's along with the normal skin. Beginners, you have to first create, because who are expertise they can directly do, but better to draw the W by some ink so that it is easy for the beginners. So after, you can see all the W's has been removed in the video. So I will show you the next photograph of the patient. You can see this patient. So there is a suture mark. So we created W. You remove all the scar tissue along with normal tissue. Then we suture. So it is the linear. The idea is to convert it to a irregular line. So the irregular line is less visible than a straight line. You can see the scar, the suture mark was this one. Now it is almost invisible after 1 month. So we did this surgery scar over the back. This patient was very much anxious, so we did a serial excision by W-plasty. Still the patient is some areas left. You can see the straight scar is now almost, there is a better scar compared to the baseline by W-plasty. Another patient, this was a very ugly scar against the RSTL, we did a W. You can see after 30 days, this is the follow-up of the patient. So the clinical application of W-plasty, short scar that is against RSTL line, scars over curved surfaces such as inferior border of the mandible, closures in the pre-tracheal area, scars or incisions along the concave surfaces where webbing or cicatricial healing is predicted in U-shaped scars. The procedure is almost utility when the scars in the areas of skin laxity, that is forehead, temple, cheeks and chin, particularly for curved contracted anti-RSTL scars. So advantage of W-plasty, no flaps are transposed. In the Z-plasty we have to do flap transposition. So it avoids distorting in areas like hairline, no risk of flap necrosis, reduction in the tensor in multiple directions, camouflaging effect, a scar is divided into multiple very small fragments and intermingling with normal skin. Disadvantage, the overall length of the resultant scar is longer. The scars parallel to the vermilion and eyelid border may be difficult with W-plasty. A certain width of tissue must be given during this procedure. This is another patient where we did the scar revision. You can see the follow-up after 2 weeks. To summarize, scar revision doesn't erase the scars. Goal is to convert the ugly scar into an ideal scar. Always try to convert the scar along the RSTL line. Both W-plasty and Z-plasty are combination of both art and physics. So Z-plasty mostly scar reorientation and scar elongation. W-plasty better for scar against RSTL line. In W-plasty, extra skin is excised along with the scar, but in Z-plasty, no normal skin is excised, no normal tissue excision is required. Counseling of the patient is must before doing the procedure. Always take good quality baseline and follow pictures to show the patients so that they will not claim because the scar is still visible. So it should be better properly counseled. We are not going to make your scar invisible at all. Thank you.
Thank you, Dr. Svetalina. So, any questions from audience?
Dr. Svetlina, good, nice, good job. Just wanted to suggest that, for example, that neck,
you can probably go ahead and do a double Z rather than a single Z. So you can actually do
Double
a
Z can be
Z,
done.
yeah.
Drum can be done.
Are there any suggestions for the angle of the W? So, are there any suggestions for that should be like so narrow or so broad W?
No, not so narrow, not so broad, and 45 degrees.
45 degrees
60 degrees.
suggested angle?
so you can go from any time between 30 and 60. Yeah.
Thank you. So, very nice lecture. And now we invite the next speaker for Magic of Thread by Dr. Dattatreya. Welcome, Dr. Dattatreya.
Good afternoon, everyone. First of all, I would like to thank the organizers of Aesthetica Asia for giving me an opportunity. Friends, today I'm going to talk about magic of threads, which also called as non-invasive thread lift, face thread contouring, face thread lift, and caddiate embedding therapy. Actually, what we do here is we insert or inject polyreductional suture into the skin, and body via syringe. We inject very thin material so that we can prolong the stimulation time. And more the stimulation time, better is the effect. These PDO threads, they generate collagen, increase microcirculation, they create anchoring effect, increase metabolism, decrease cellulite, and ease the muscle. These PDO threads are manufactured by polymerizing a monomer called as P-dioxanone. It is a synthetic absorbable material which takes longer time to get absorbed compared to other synthetic absorbable. It is almost 180 to 240 days. So it has got longest tenacity, sustainability among the biodegradable sutures. So now it is used for lifting and tightening the skin. The basic mechanism of threads to work is wound healing effect where there is inflammation, there is a remodeling. What it does is it creates collagen by foreign material. It has got anchoring effect which gives lifting. Increased blood flow causes increased metabolism and cellulite breaks down, and muscle relaxation causes muscle volume decrease. So this effect also encourages the skin tightening by improving the fine line wrinkles, deep wrinkles, and the lifting effect causes defined jawline, decrease in nasolabial fold, drooping cheek, double chin line, and cranky lines around the mouth. This also improves the skin tone and whitening because of increased blood flow to the face. Also improves cellulite and body correction. It gives a defined jawline. So this effect is called as mechanotransduction. This is the ability of the cells to sense, process, and respond to mechanical stimuli. This is also called as orthotherapy effect by supplementing cells, skin, bones, and joints. So it is an important regulator of physiologic function that has been found to play a role in the regulating gene expression, protein synthesis, cell differentiation, and tissue growth. And the most recently pathophysiology of the disease. Now, this increased microcirculation causes increase in the eosinophils, which secretes more of histamine that leads to tissue fibrosis, giving to lifting effect. It is like getting acupuncture every day so that there is a good radiance of the skin. Initially, the threads used were catguts, and the source was animal, so there was highest rejection rate. Then came polyglycolides, they were multifilament. The infection rate was very high, and then came these polydoxin sutures, which are monofilament, virtually infection-free, and very easy to manufacture. What we treat with threads? I'm going to be more clinical. In old people, right from forehead line to brow to eardrums, crow's foot, nasolabial folds, maronite line, and mental creases. But also in young people, you can use for glabellar lines, worry lines, periorbital lines, nasolabial eye lines. So which thread to select? I always follow Glagau's photoaging classification. In type 1, early photoaging, which is a group of 20 to 30 years of age, I use only mono threads. In type 2, which is early to moderate photoaging group, 30 to 40 years of age, they have senile lentigines, palpebral keratosis. Here I combine mono threads with cork threads. Third is advanced photoaging. 40 to 50 years of age, dyschromia, telangiectasis, visible keratosis. Here you have to combine threads with either Botox, fillers, HIFU, or lasers. Fourth is 60 to 70 years old group, no normal skin, all grey skin, pre-cancers. Here you have to use all the armaments in your capacity to use and get the good results. To select the good patient, always concentrate on mid-face aging. If the mid-face aging is hypotropic, never ever use threads, only use fillers. But when it is hypotropic and protic, or protic more and hypertropic, here you have to combine threads and fillers depending upon what quantity you need. But when there is a hypertropic and protic phase, there only threads are required, no fillers. We have to also know about SMASH, which is a distinct facial layer from platysma frontalis into gallia penultica. It is a fibromuscular network that envelops superficial facial muscles and distributes the facial muscular contractions. So we have to target that in threads, that's why you have to know a little bit about that. Also the anatomy of the muscles of the face, right from procerus to mentalis, because which wrinkle or which fold is caused by which muscle you should be aware of it. Whenever you insert the needle, you should be around 45 degrees of the angle, and in case of monos, your target plane is epidermis. In case of cogs, it is subacute. So whenever you move, you have to have parallel direction to the skin. Very important part of the thread is consultation. Until and unless you do consult properly, and if you do not counsel the patient properly, you are going to land up in trouble because it's a big money involved. So you should always explain the patient how treatment works, number of treatments required, and number of sittings required to reach the decided goal. And also the length of time patient is going to show the changes. Every time you do the process, even the touch-ups, you have to take consent. You should avoid this in pregnant ladies, keloid scarring, poor wound healing, anti-seizure, herpes, psychoneurotics, non-compliance, and unrealistic expectations. Ideal patients are light skin, non-dynamic rhytides, superficial scars, impurities, epidermal lesions, and large pores. Usually there are no complications. If at all they are there, then there is like granulation, bruises, edema, pain, and sense of muscle contraction, which is there for 5 to 7 days. And if you do not select the patient properly, then there is going to be no change how many threads you put. There can be asymmetry, there can be aggravation of the problem, visible threads, dimpling, and second infections. You have to be careful. The instruments required are very simple, right from drape towel, scissor, forceps, which are usually present in even general practitioner's clinic. You do not need any special equipment for that. These are the vectors drawn for the monocoques for complete facial lift, right from hairline up to the necklines. I use around 50 to 80 mono threads to do the complete facial lift. There are two techniques of putting threads, basic techniques. One is fan technique, which I use for cogs, where the insertion point is same and you go in fan technique. Other method is cross hatching technique, where you have to, where I use for the cogs, and you have to do perpendicular to each other so that the mesh is formed. There are different types of threads like mono from 25 mm to 60 mm, screw threads, single, double, twins. The new threads have come, cog threads in the type, they are outdated now, but cannula threads are there. 310 was very thick, so we don't use that. The cog threads unilateral, but new cogs which we use are these. They are bilateral and bidirectional, having cogs in opposite direction, 20. New threads have come in the picture, that PLCL, which is poly-L-lactic acid, which is very rigid, and polycaprolactone, which is very soft. They have combined this. The advantage of these threads, they have a very good longevity. They remain in the skin for 14 to 16 months, and they work as a scaffolding for the tissue augmentation. Even tissue augmentation takes place with these threads. Certain areas, like if you treat oral areas, you have to be careful. You have to use 29 gauge needle only because it's very sensitive and painful. The crow's feet and teardrops always combine with threads or fillers to get good results. The glabellar complex also, bunny's line also, you have to take help of Botox. It gives excellent results. Zigzags, you can use as many as threads you want. With more the threads, more collagen, more the lift. Even protruding oral cavity also can be connected. When you put the threads in the shown direction, it gives very good results. I'll show you in my cases which are done. So there are techniques also different, where you have to insert the threads in a different way. Step ladders, same level insertion, narrow interval insertions, mesh technique, needling and twisting and fancy as I told. Now these are the vectors for mono threads for jawline. You have to give these threads in shown direction, and you have to come towards neck area 1 centimeter below the mandible line. Now this is for double chin. You have to use this shearing technique, where you have to use threads at 0.5 centimeter away from each other and make a mesh like shown in this picture. This is for the sack cheek. You can use as many as threads. Once I use around 20 to 30 threads on one side to get good result. Here also, if you combine with the fillers, it gives good result. This is for nasolabial. Around 12 to 16 threads are used and mesh is formed, gives very good result. This is for marionetal, and again at 12 to 16 threads we use in the shown direction, and it gives very good results. This is for crow's feet. Here also again I form a mesh, but I take help of Botox or botulinum toxin. This is for threads between the eyes around 15 to 20 threads are used, but for complete forehead we use around 30 threads as I have shown, and again it gives a very good lift. It has got little bit of no bar area around 2 cm in the center. Now new threads are come, they are also for nose threads where we use for hump nose, short nose, dorsal augmentation, nasal width reduction. We use around 5 cock threads at the dorsal and 5 for columella with very nice results. When you choose the patient, say that should not be very obese or very thin, it doesn't give good results at all. Anesthesia, yes, you can use local as well as injectable anesthesia like lidocaine with adrenaline. You can combine these procedures with HIFU, lasers, Botox and fillers. Now these are the vectors done for the cock threads. You have to draw a line above the outer campus of eye and you can have this kind of insertion for the jawline correction. This is for nasolabial fold, 1 centimeter in front of tragus. You can draw this kind of vectors and you can lift the nasolabial fold. This is for marionette line, just 1 centimeter in front of the mandibular angle and 1 centimeter above the mandibular angle. Very good results. Around 3 to 4 threads are used for jawline correction. These are my few cases. In this lady, I have used just 12 threads, 6 on each side, forming a mesh, and I could correct her tear tuft, zigzag nasolabial fold, and defined jawline. This lady, I have used only 6 threads, 3 on each side, and I could correct her nasolabial fold, even defined jawline, and protruding oral cavity. This lady, I have used 12 threads, 6 on each side, and I could correct her nasolabial fold, protruding lips, skin texture, and defined jawline. This lady, I have used 10 threads of 50 mm each side. She was my demo patient in one of the workshops, and I could correct her asymmetry up to 80% without getting her under knife. This 60 years old lady, I have worked on 2 months. First I used 50 threads on her, then followed by Botox after 4 weeks, and in between 3 sittings of IPL laser, and after 2 months she was looking like 40 years old lady with tight face and defined jawline. At one go, you can use even Botox and threads together. Here I have used around 14 on each, 28 mono threads with 15 units of botulinum toxin, and I could give her inverted triangle jawline as she had squarish jawline. This lady, I have used around 14 threads on each side, 28 monos and 1 filler for her tear tufts and 3 sittings of microdermabrasion pill, and after 2 months she was very happy with the result. Till today she is my patient. You can correct even brow droop. This man had little brow droop on the left side, so I could correct it with the cock threads, which is around 3 cocks on each side and 4 monos on each side, and I could get rid of this vertical forehead line. This lady, I have combined cocks and mono threads, 10 monos on each side and 6 cocks on each side. After 6 weeks, she had a very nice skin texture with quite a good facelift. This man, I have used HIFU. After 6 weeks, I put him on cogs, and after 4 weeks, I put around 12 cogs, and I called him for follow-up, and he was very happy with the facelift, skin texture, nasolabial folds, and jawline. This is just immediately after cock thread. Still, you can make up 30 to 40% lift in the patient's face. This is also one of my demo patient I did in Hyderabad. She is a Kathak dancer. Immediately after doing cogs, she could get a very good facelift.
You are running short of time.
Yeah. This lady was the wrong choice by the people who have organized this workshop. She should have done HIFU first and then threads, but still she was very happy with the result. This is again Botox with cogs. This is again fillers with cogs I have done. This lady, I worked for 4 months, first HIFU, then cogs, then fillers and lasers. I could give her defined face. This is again cogs and monos. This is immediately after cogs. This is again cogs and monos, 4 on each side and 5 monos. And this is for complete facelift. I have done with the PRP, and this lady had a very good result. I do rhinoplasty as the non-surgical, just 5 monos and dorsum, 5 in columella, and put one filler above that, which works as scaffolding for the filler, and you get very good rhinoplasty. This is also one of the rhinoplasties I have done. This is Botox and thread lift immediately after this. Double menarini also you get good results. Breast lift also we do striations also, and it gives wonderful results. This is a time, boys, to really do threads. Thank you very much.
Thank you, Doctor. Thank you, sir. Thank you for a wonderful talk. Now we do have Dr. Rekha Nair. She will be Now she will be talking about two procedures in acne scars. So she is a consultant and she will be talking on the acne scars, comparing the two procedures.
Is it audible? Yeah. Okay. A very warm good afternoon to all of you. So this is a post-lunch session, and I hope it's not going to be boring for you and put you to sleep. So I've kept some videos also, at the very outset, I would like to thank Dr. Arandata sir and the organizers of Aesthetica Asia for giving me this opportunity to speak here today. So as we all know, acne scars, any scar for that matter, is really traumatizing for the patient as well as the doctor who has to face the patient, because some of the scars are really old and they come to you and they are in such, scars are such a stigma. So many of the college going students come saying that it's so difficult for them to go to college, and they are anxious about it, and they cannot face their peers because of the acne and the acne scars on their face. So I think it's a very important area to target. So today I'll just be comparing, it's basically a microneedling, but we'll just compare the derma roller as well as the derma pen, the latest, the original derma pen 4. No conflict of interest. So the evolution of fractional skin rejuvenation started with acupuncture, and then came subcision in 1995, and then came needle dermabrasion of the colorless tattooing 1992 to 1997, then the needling stamp, the needling roller in 1996, and then came the derma pen in 2010. So this is our conventional derma roller. I think almost all of you must be using this. The derma roller, which comes with multiple pins, and this is what first came into the market, and we are used to using that. So there are different types of derma rollers, the C8 one, which is cosmetic, the CHE one, which is for the hair bearing areas, especially the scalp, the CIT8, which is the collagen induction therapy, the MF8 1.5 millimeters. So there are different millimeters for different areas as well as the depth of penetration. The MF4, which is a smaller cylinder type, 1 centimeter length and 2 centimeters diameter, and 4 circular arrays of needles, that is 96. 1.5 millimeters has got better precision and deeper penetration, the MF4. The other types are 0.5 to 0.75 millimeters periorbital as well as perioral areas. The mechanism of action is basically to create micro injuries. So when there is a micro injury, there will be release of growth factors like fibroblast growth factor, transforming growth factor, platelet derived growth factor. There will be breakdown of the fibrous collagen strands which pulling down these scars, neocollagenesis as well as neovascularization. And collagen fibers which are formed is usually formed in a normal lattice pattern, more so in the case of Dermapen when you compare it with Derma roller. So there was a study in which there were 6 sessions, 1 month apart, assessment 6 months post-op. Histopathological examination showed 400% increase in collagen and elastin, and 1 year post-op showed increased pattern spinosum and normal rete ridges. So it's basically a controlled injury with minimal epidermal damage in case of the Dermapen compared to the Derma roller. The other mechanism is the resting electrical membrane potential of the cell is minus 70 MV, and microneedling makes it to minus 100 MV where there is release of growth factors. So the body is really fooled to produce the growth factors. That is another theory. So in the Derma roller, we go in different directions, the vertical, the horizontal as well as the oblique directions, and the pinpoint bleeding is where what the end point generally is. And we massage in the blood, which is usually there. You can even use other topical agents also like vitamin C. You can combine it with platelet-rich plasma. This is subcision with microneedling, pre and post. But however, the complication of the Derma roller, when we compare it with the Dermapen, is the pain is more because there is a larger area of the epidermal area which is being traumatized. So if the scar, there are multiple areas in between the scar which may also get injured. Then hyperpigmentation, the tram track scarring. If the skin is really dry, you can produce the tram track scarring, ecchymosis. So different types of atrophic scars, the box scars, the ice-pick scars, everything can be targeted. Even the hypotrophic scars can also be targeted with the Dermapen. So this is the Dermapen 4, the original one. It has got a cartridge and there are around 12 to 16 needles in it. And the technique is mainly the AOVN technique, that is the advanced oscillating vertical needling. So the amount of injury that is produced is less and the depth can be adjusted. So AOVN technology, adjustable needle depth from around 0.2 to 3. So at different areas, you can go at different depths, and to target different scars, you can go at different depths. Ergonomic design, so it's easy to be held, multiple speed motor, the oscillation is really fast. So it is like, than the earlier Dermapens which we used to use initially, which are there other ones which are available. This is around 4-10 times faster. Easy click system, reusable pen base. The treated areas heal quickly and there's virtually no downtime because the epidermal damage that is created to the surrounding area is less. It does not use any synthetic chemicals. Dermapen is a minimally invasive procedure. It does not cause any unnecessary trauma to the surrounding skin. The procedure does not involve heat or thermal energy. Allergic reactions or side effects are highly unlikely to occur. So this is basically, demonstrating how the treatment procedure goes. So first you need to cleanse the face. Then after clearing, you examine, document, photography is done as well as a consent is taken. Then you apply the EMLA, sterilize the area with betadine, Dermapen is kept ready, and hyalactin, that is a hyaluronic acid, vitamin C complex is available. You apply it onto the skin and then you select the depth according to the indication. Okay, whether it is the acne scars or it's the wrinkles you want to target or the periorbital or the perioral pigmentation, depending on that you can select the depth and the oscillation speed is kept. Now this is a treatment directional chart. If you see in the Dermapen can be used very easily in the periorbital as well as the perioral area where it is very difficult to use a Derma roller. You can create more of injury in those areas because it's very thin skin. So usually in the periorbital region it is the 0.25 to 0.5, then 0.5 to 1 around the nasal region and so on and so forth. And you have to create multiple, you have to go in multiple directions. So treatment, post-procedure is again cool the area. You can apply a mask which contains vitamin C or collagen. Then an antioxidant cocktail which comes with this can be applied, again containing vitamin A, C, E as well as hyaluronic acid. Then a breathable camouflage is finally put. It's a repair cream along with a camouflage. Then if it offers thermal free and non-ablative technology that eliminates the risk of melanocyte heat injury and abnormal fibrotic formation. So the elastin as well as the collagen is in a normal lattice form, and the pigmentation is less because there is no injury to the melanocytes. So it preserves the epidermis, providing the most ideal balance between optimal results and minimal downtime. So the redness as well as the pain or irritation which is there with the the derma roller is less with this. So it can be done as an office procedure and the patient can go back to work. So if you compare with the lace, you can also combine them with lasers, subcision and the other technologies. Then treatment contraindications are papular pustular rosacea, herpes simplex, scleroderma, open lesions, skin cancer, acne vulgaris stage 3 to 4 where there is lots of non-cystic acne and it's very painful for patient. Warts, bacterial fungal infections, solar keratosis, hemophilia. Then treatment considerations, in certain conditions you need to know the pros and cons and then treat, like pregnancy, cardiac conditions, anesthetic allergies, autoimmune disorders, certain medications, medical aesthetic treatments and clinical aesthetic treatments which are done along with this, then topical skin care regime. So the wound healing response, inflammation 1 to 5 days, proliferation 2 to 21 days, and maturation 20 days to 24 months it takes for the collagen replacement to continuously occur. That is why we can do it at 1 monthly interval, around 4 to 6 visits are required. So control healing, epidermal integrity is there, scarless wound healing, minimal downtime, customized treatment as well as patient safety. Post-operative recovery, up to 24 hours there is erythema, petechia and minor swelling. 1 to 2 days mild erythema, petechia, there is reduced swelling, minor itching, dry or tight sensation. So the patient needs to use a lot of moisturizer. 2 to 3 days reduced erythema, fading of the petechia, and usually there may be mild skin flaking. 3 to 4 days there may be dryness, 4 to 5 days full recovery. However, if you keep on applying the good moisturizer, in 1 to 2 days the patient is perfectly fine. Then application of active topicals. See, when you do the derma roller, the depth of penetration is less. But when you use a derma pen, you can go up to 3 millimeters, and when the oscillation speed is fast, the AOVN technology, that is the oscillating vertical needling, at a very fast rate, what happens is that there is mild separation of the epidermal cells and there is deeper penetration of the topicals which are used. Again, a picture depicting the indications and treatment depth. This is again pre and post, that is usually after 4 sessions, the first and the second. Then we have derma stamp, that is 0.2 to 3 millimeter depth for isolated scars like the chickenpox scars. Derma frac, that is combination of microdermabrasion, microneedling, deep tissue serum infusion and LED light. So I think I'll just show you this video. Machine as well as the cartridge which we are attaching to the machine. So this is how the derma pen looks like, and this is the cartridge. It's very easy to fit it inside. It's a sterile cartridge, so we insert it and then it is rotated and fitted into the derma pen. Now if you see, the derma pen has got a screen on which we can adjust the depth of the needles. Here it is 2.5 now, and certain areas you need to reduce it, and by touch we can reduce it to up to 0.2, and then we remove the cover of the needle. We can see that the cartridge contains multiple needles, and we usually vertically orient it and it is started. So this is the mechanism by which our derma pen works. Next one is the procedure being done. So you need to move it a little more faster, I think. I think I'll skip it, sir. The thing is, you can go on different areas in the different directions, and in certain areas where the depth is more, you can go at a deeper level and do a punching like motion. So it will be better. Thank you so much. Apart from this, one thing is you can combine platelet-rich plasma along with this technique. It gives excellent result. You can use this on the scalp for androgenetic alopecia as well as female pattern hair loss along with the PRP. The pain is much less when compared with the derma roller. So thank you.
Thank you, chairpersons and all the speakers for the session. I request Dr. P.K. Roy sir to kindly felicitate our faculties. So we'll move on to the next session. For that, request Dr. K.G. sir and Dr. Brijesh Nair sir to kindly chair the session.
Hello. Good afternoon. This is a very important session, but the post-lunch session is good for yawning also, and yawning is very infectious. So let us proceed with this new session. Of course, bioequivalent of tofacitinib by Dr. Kamini Desai. I invite Dr. Kamini for her talk.
Good evening. I am Dr. Kamini Desai, at Medical Services with Aesthetica. Thank you for being in this session today. I am here to present to you the bioequivalence data on. But before that, I want to make a on pharmaceutical quality, bioequivalence, and being that it is the pharmaceutical quality that instills confidence in you as a patient, that the medicine that is prescribed to them and by you.
Mic, please, mic.
Okay, so what I was saying is, it's the pharmaceutical quality that instills confidence in you as a doctor and your patient that the medicine will work as intended. And there are various determinants that add up to the pharmaceutical quality of any formulation. Apart from the API, it is the raw materials and excipients, the fact that every processing facility is different, and then there is the color, the coating, the packaging, which all adds up and finally decides the price of a product. At MSN Laboratories, we have a strong philosophy of quality because we believe that every life matters and everyone deserves the right to quality medication. With that kind of a philosophy in mind, our facilities and our manufacturing plants have more than 30 approvals from regulatory authorities from across the world. Because of such high quality standards, Our products are purchased by global giants like Novartis, Merck, Mylan, just to name a few. That brings me to the second part of my talk, that is bioequivalence, which is another critical aspect of quality. Bioequivalence studies basically determine that the products we produce here are not only of high quality but are similar in safety and efficacy to the innovator molecule. We have to conduct bioequivalence studies when we have to develop genetics of innovator molecules, and we compare the pharmacokinetics, we study the influence of processing factors, storage and stability. We compare drugs or substances that are produced by different manufacturers, and to finally ensure the safety and efficacy tolerability of these new drugs that we are producing. So the criteria that has been set internationally for calling two drugs as bioequivalent is that you can call them not different from each other when the 90% confidence interval data of the pharmacokinetics of these two drugs the log transform data falls well within 80 to 125% of each other. And when we conducted bioequivalence of our topaldose manufactured by MSN Laboratories and compared that with the innovator molecule Zenjans, which was manufactured by Pfizer, it was an open label randomized two-treatment study, which was a single dose study on 21 healthy subjects, and compared the primary pharmacokinetic parameters and the safety profile in these patients. So if you look at the data, the pharmacokinetic parameters of both the test products, that was MSN Labs Topaldose, and the reference products, that was Xeljanz, made by Pfizer, the parameters were almost similar to each other. And when this data was statistically plotted and log transformed, the ratio fell well within the range of 80 to 125%. So we met the international criteria set for bioequivalence. This was the linear plotting of the same data, where we plotted the pharmacokinetics of both the drugs. And in terms of safety parameters also, there were no serious adverse events reported in the study. And hence, we could conclude that our molecule was bioequivalent with the innovator molecule and of global standards. I would like to end my presentation by reiterating the fact that although we are new in dermatology, we are not new to the pharma industry. We have been around for quite some time, and we have 21 manufacturing plants across India and one in the United States. All of these plants have more than 30 approvals from regulatory authorities from the US, Europe, and rest of the world. We have managed to roll out more than 300 bioequivalent formulations and have more than 450 APIs manufactured. That actually puts us on the top of making us the company with the highest number of APIs manufactured by a single company. Our R&D facility in Hyderabad is one of Asia's largest facility with more than 900 patents for API and formulation innovations. We have a dedicated team of more than 2,200 scientists working across more than 50 labs. We are also ranked #1 globally in the US DMF filings with more than 455 drug master files. With that, I would like to end my session, and I would also like to extend a warm invitation to any of the delegates present here. If you would like to witness our facility, our manufacturing sites, you can get in touch with any of our staff members present here today from MSN, and we will be more than happy to give you a tour of our facility. Thank you so much for your patient listening.
Thank you, Dr. Kamini. So for the panel, we have exchanged because the moderator had flight, so he left. So I have requested Dr. Manas Chatterjee sir to kindly moderate the panel. And among panelists, we have Dr. Anjali ma'am, Dr. Anju Jha, and Dr. Smita Ghate. Is Dr. Rohit Bansal around? No. So we have 3 panelists. Dr. Anju Jha, Dr. Anjali ma'am, and Dr. Smita Ghate. Anush Chatterjee sir, kindly moderate the session.
खोल दीजिए उनका.
So let me sort of, okay, I was actually, I think this is the first time for me.
Sir has been very kind to consider my request.
Iska request I can't refuse.
No, I'm done, sir. I'm waiting if there are any questions.
If you want, you can join the panel.
Yes, I think that will be a good idea.
You can join the panel.
Yeah, I think that will be a nice idea. I will ask you some questions. Some queries that previous clinicians have. Okay, this is really a first time for me that I've been told to moderate a panel discussion. Being a panelist is not a problem, but to moderate a panel discussion with a 30-second notice. Let me see how we can how do we do this? I don't need this. हाँ mic चाहिए होगा. So okay, so you'll have to bear with me. Let me sort of just see one of my talks and let me see if I can get something out of it. Okay, so we have our product is always better than the equivalent product. For topicals, the common thing is the word called excipients, and they say that we've got better excipients, and for systemic drugs, it is always stated that look, there are other factors other than just the medicine which work on the efficacy. So what do you think about what pharmaceutical companies, the originators tell us about the quality? We know about this 80 to 122. I didn't know what is 125. Brijesh, were you aware of 125? I always thought 80 to 120. That was our idea, when we talk especially about biologics. So I mean, just establishing pharmacokinetic equivalence, is that enough? Or is clinical equivalence also important? So you've established, by pharmacokinetic data that the two drugs are equivalent. But could there be a difference in terms of clinical efficacy, even though the pharmacokinetic parameters are the same or similar? I think we need the
To answer your first question, sir, no doubt the innovator molecule is of a very high quality and standards, preparing a generic or manufacturing a generic is different in the process, okay? But bioequivalence will prove the efficacy and the safety and efficacy of the formulation from a pharmacokinetics and dynamics point of view. And the clinical use of tofacitinib in India, produced by Indian companies, has shown equal efficacy and safety. We have data on Indian patients. So as far as tofacitinib goes, we can vouch for the quality and the effectiveness of the drug. Yes.
Do you need to do some clinical equivalence studies? That's what I sort of...
If it is mandated, we are ready to do, and we only get...
But is it mandated?
So, we are the first, we were the first entrants in the market, it was mandated, and then we did clinical trials and whatever was required by regulatory authorities to prove the safety and efficacy and our capability to introduce a safe molecule into the country, with global standards. So yes, we met all those criteria.
Okay, thank you. Madam, I wouldn't know everybody's names, so I'll just sort of...
I'm Dr. Smita Ghate.
Okay. Yeah, so... I'm so sorry. So, madam, this is regarding drug interactions. So how important are drug interactions in a drug like tofastinib? I mean, in clinical practice, how important are drug interactions?
Which drug to be given along with together?
Yes, so in terms of, are there any drug interactions which you would clinically be wary of, in clinical practice?
Yeah. In my clinical practice, I usually don't mix tofacitinib with any other drug. Means I give it as alone.
So would everybody agree with that, or you don't mix it with any other drug?
See, I want to clarify one thing. I am not a dermatologist. I am a rheumatologist. So my use of...
Perfect. So it's nice. I'll ask you this question. Tofastinib, I'm sure you use tofastinib.
Yes.
So what are the drug interactions, or are you not concerned? Are you really concerned Dr. Smita doesn't use it with any drug at all?
No. See, drug interactions are there. We have to be very careful when we are giving with drugs like warfarin. We have to be very careful for CYP drugs interaction. So dose has to be reduced. Even for methotrexate, full dose of methotrexate, I am talking about arthritis where I am using rheumatoid arthritis or psoriatic. I have to reduce the dose of methotrexate and then add this as an add-on. Because chances of LFTs, RFTs and
No. So you are talking of using methotrexate with because of hepatotoxicity.
Yes.
I am talking about pharmacologic drug interaction.
Pharmacological interaction, warfarin. It has to be used very cautiously. Warfarin may not be used, or dose has to be monitored very clearly because warfarin toxicity can occur.
Any other drug any of you would be sort of concerned about? Open this now, madam.
And maybe we use cyclosporin also, so whenever we are switching from one medicine to other, we don't stop the earlier one, so we have to be careful. Like with methotrexate we can give, but with cyclosporin I think we cannot give tofastinib.
But any okay, what about drugs which act on the microsomal system, the hepatic microsomal enzyme system? Are you sort of really concerned? She mentioned fluconazole.
Maybe ATDs.
Okay. Rifampicin probably?
Yes, maybe, but since I've not used, I'm not.
What about itraconazole? Yes, sir. What about itraconazole? Because a lot of our patients are on itraconazole. It's almost like dietary supplement. I'm asking about itraconazole because it's not a drug which is commonly mentioned, and I would really like a view on this.
I think I'm using this tofastinib for last 4 years.
Yes, sir.
There are 450.
You've got extensive experience, sir.
And talking about the fluconazole, there is a lot of...
Itraconazole, sir. Itraconazole.
He said it cannot be given with tofastinib.
Sir.
I'm coming to the basic. The CYP3A4, metabolism is through CYP3A4. Itraconazole also same. So itraconazole cannot be used. Statin will have problem. Rifampicin will have problem. All inducer will have problem.
But this is an inhibitor. The fluconazole is an inhibitor.
Yeah, all inhibitors.
And rifampicin is inducer.
Metabolism through CYP3A4.
Yes, sir.
That
Yes,
is
sir.
basic. But fluconazole, most of the metabolism is through 2C19. It is not through CYP3A4. So it is mistaken by many people. They take it itraconazole, fluconazole from the same group, and that's why they say itraconazole, fluconazole. So don't take it easy, fluconazole can be given.
Okay. And what about itraconazole?
Itraconazole cannot be given.
Okay. Any other? So what do you do if you can't give rifampicin? Somebody who's on anti-tubercular drug.
Yeah, you can give moxifloxacin because we see 3 to 4 patients of TB every day for last 30 years. So rifampicin always can be avoided. You can give moxifloxacin, no problem.
Okay. So do you? And what about hepatotoxicity and renal issues? It was discussed that it's got the hepatic hepatotoxicity is much more than renal, because the renal the excretion through the kidneys is to the tune of 30%. Most of it is, of course, through the hepatic enzymes. So, are you really worried about patients who have got renal problems, and how do you monitor these patients? Anybody can sort of take that on.
Patients with, again I'm talking in terms of rheumatology point of view,
absolutely,
not
no
for
problem.
the skin point of view.
Yeah.
So we have alternative drugs. If tofacitinib is basically a cheaper alternative to biologics. So when tofacitinib in rheumatology we are using, it is related to when conventional disease modifying agents fail, like methotrexate, leflunomide, hydroxychloroquine altogether fail, then either biologic, which was the earlier choice, as soon as tofacitinib has come into picture, we have that much option. So if it cannot be given because of hepato or renal toxicity, then of course biological is the option that we have. And if patient has a problem with kidneys, then rather than making things worse, I will switch over to the other agent, like biologics also are a very good agent. Only thing is cost is the problem.
Okay, now I'll come to adverse effects.
Unless I'm disturbing you, but then I must say, tofacitinib in hepatic problem, you have to be very careful. But the renal problem, that is the drug of choice. I'll tell you, one of the doctor came with extensive bullous pemphigoid. He had a diabetes, he had a hypertension, and he had a creatine 5.5. Because which is a drug that can be biological, as you said, the biological can be given, but then he refused. We started tofacitinib. He is on tofacitinib for last 2 years. Tofacitinib can be given with a renal problem, there is no problem.
What was the dosage you gave, sir?
Pardon? See, when we give a dosage, always you give 10 milligram BID first 2 weeks, not 1 BID. 2 BID, then only it works, and then he came on reducing and economic.
Okay, my next question is on her. Yes, ma'am.
For renal, I think for most of the drugs it is like this. It depends on the glomerular filtration rates. So if it is more than, if the renal clearance of creatinine is less than 30%, then only we need to be more careful. But otherwise, I think we can give.
Okay, now I'll start with you, madam, about...
EGFR is not considered. EGFR is just calculation. Just you are calculating. It is by the creatine is more important than EGFR. The EGFR, according to theory, should not be given, but you can give by monitoring. There is no contraindication for EGFR.
Sir, I have one question. My highest dose of tofacitinib can be given to adult?
Highest dose of tofacitinib. So anybody has a response to that? Otherwise, I'll respond to it.
We are giving 11 milligram for our indication.
That's a regular dose.
We are not giving other
So what do you do in patients? I think somebody mentioned in the morning psoriasis. So psoriasis does not respond to the regular dose. You'll need to go to 20, even 25 milligrams. I have used up to 25 milligrams. But there's one question for you, and that is herpes zoster risk. Now, is there any increased risk of herpes zoster?
Yes, there is.
No, wait. In your patients compared to our patients?
Yes, there would be, because
this is important. This is important.
Patients who are on steroids.
Yes.
That is a very high risk factor.
Yes.
And some of our patients, of course, SLE, tofacitinib we are not using in any ways. But these patients who are on higher immunosuppression have very high chances. Plus, our vaccination status and other nutritional status and all other things also come into picture, their immunocompromised status in general. So herpes zoster, always there is a chance, and with tofacitinib definitely it has been produced. One of the highest adverse events are related to herpes. So definitely.
So one is concomitant steroids, which you all use. It's not something we use, but we can. The second thing is there any increased risk per se in patients with rheumatoid arthritis or ulcerative colitis as compared to, let us say, psoriatic arthritis?
Psoriatic arthritis.
Because you're a rheumatologist, I'm taking
psoriatic arthritis, we do not use steroids much. So,
yeah, but even if you're not using steroids, is there a de novo increased risk in these disorders?
Rheumatoid arthritis, yes.
Okay, so this is important. So the risk of the tofacitinib-induced herpes zoster seems to be higher in rheumatology patients than in dermatology patients. So therefore, so in our patients, I don't know how much of reactivation of zosters, I mean, we've seen in this hall. Anybody can raise their hands how many zoster reactivations? So 2. So that isn't a lot. But in rheumatology, it seems to be much higher. That is an important point. Sir, you were making a point.
Yeah, in a herpes zoster, even there is a reactivation. The reactivation, they get a very small group, one group of the lesions, at the most 2. What you get a conventional, you get quite florid presentation. Here you get very few group of vesicles, and you can give acyclovir, and you can continue tofacitinib. There is no need to stop it.
No, that's okay. We were actually discussing something else. We were discussing the risk.
The risk factor in the last 4 years, I've seen only 3 cases.
Now my next question is exposure to a patient of tuberculosis a contraindication to tofacitinib? I'm not talking about tofacitinib. Is exposure to a patient? मेरे को जितना देर बोलने के लिए बोलोगे? Okay. मेरे को 30 सेकंड पहले she said, sir, moderate करो. So the question is exposure to a patient of tuberculosis a contraindication, relative or otherwise, to tofacitinib? So she is the only one who seems to agree with me. So you can sort of say, because this is something which is a little, so they are people who go through the literature pretty extensively, and that's why I asked this question. Because this is something which is again important for all of us. Madam, please go ahead.
Yes, so as far as oral therapy is concerned, yes, you have to rule out the possibility of tuberculosis. If a patient has past history, then you have to really evaluate the risk and benefit before starting.
So if there is a tuberculosis exposure any time in the past, that becomes an important relative contraindication to using tofa. I think I've been told that ends my time.
Active tuberculosis.
Lipid dyslipidemia.
Okay, so there was, yeah, so that's interesting. In fact, there was these slides, I think Manas's slides in the morning, which said that, is Manas around? No, I'm also the other Manas, but he's the Manas. So he actually, 3 monthly, he did not have lipid profile in his list. If you would have noticed those slides, I was, yes, so what is your sort of, sort of your take on continuous profile? So yes, start at 3 months, but thereafter, would you also continue to monitor lipids, or would you stop monitoring lipids? Because from those slides it appeared that you don't monitor lipids.
And do we have to give statins for that, or the simple dietary restrictions?
Lipids have to be monitored every 3 months.
Mike.
And it invariably increases.
It increases, so we have to monitor. We have to every 3 monthly CBC, LFT, RFT, and lipids have to be done.
And the second question is statins. So do we use statins? Of course we do. Of course we do. Depending on the lipid elevations, we use statins. So I think there was something wrong with those slides. I continue to monitor lipids, and my
idea of asking was that.
Yes. So those slides, actually there was something wrong in the continued monitoring. Thank you so much, ladies and gentlemen, and Shwetlina for giving me another opportunity to talk to you.
So thank you, sir, doing the moderation on my request. That is an emergency. Thank you so much, and thank you all faculties. I
Thank you,
request K.
organizers.
Lokendra sir to kindly felicitate our faculties. So moving on to our next session, I request.
Thank you very much. Thank you, the organizers, for giving this opportunity to us. Thank you.
I request Dr. Dattatreya Swarnarayana sir to kindly chair the session and Dr. P.K. Roy sir to join.
नहीं पता मुझे नहीं पता है तो मेरा नाम लेकिन करते मुझे नहीं पता 3 पैकेज में 4 बन गए इसके बाद क्या
जर्नी का टिकट लिया था नहीं लिया था
हाँ शुरुआत तो आप ही के यहाँ से की थी ना आपने सबसे पहले ग्रीन सिग्नल दिया था
बोल देना ये
90 में गुरु भी यहाँ गए मेरे को
सबके गुरु हैं
हाँ
Hello. I would request Dr. D.G. Sapile to speak on how chronic generalized dermatophytosis affecting the quality of life, physical, mental and aesthetic.
Thank you. Hello. Hello. Can you hear me?
No.
Hello.
Hello. Yeah. Hello. Yeah. Thank you very much for inviting and giving me this opportunity to talk about psychosocial problem of recalcitrant dermatophytosis and its remedy. Of course, I'm working in this for last about 5 years because I was involved in HIV all the time. Then I realized there is a problem of dermatophytosis, got involved in the research of dermatophytosis. When I got involved in dermatophytosis, started giving the talk across the country. I was talking at Goa, where there was from all other faculties, gynecologists, physicians, psychiatrists, and one of the psychiatrists got up and he said, "Doctor, do you know most of your tinea patient is treated by me?" So I was shocked. I said, "You're a psychiatrist, how come you're treating?" So he said, "They come to me young people who want to get married. They are extensive lesion. They said, we can't get married. How long we can wait because the disease is not coming under control." So there was a psychological problem, the marriage problem. For that purpose they go to psychiatrists. So there are a lot of psychosocial problems. Like take for example of this patient. This patient said, "Sir, I cannot wear any fashionable dresses. I cannot go for any function Because the pigmentation, you know that pigmentation is this. See, this is another patient, he said, I cannot go for the swimming. This is the patient, he said, sir, my sexual life has been disturbed. My partner is not happy with me. So now this lady, her whole face has been involved. And the whole face is involved, of course, she said, I cannot go to the market, even buy a vegetable. So these are the various psychological problems they are dealing with. And already you are seeing in the patient, then there was a lot of study, they said the T metagrophytes is on the rise. For last 5 years I am working in Bombay, doing culture and sensitivity. I not found a single patient of T metagrophyte. All there are T rubrum, but that is a finding from Mumbai. And but in the north they say that T metagrophyte rise. Of course, there are a lot of problems. One of the problems is a persistent itching, even the disease comes under control. These are the types of patients you must have seen. Extensive tinea, this patient was suffering for 2 years. This is the unusual site. Various types of presentations you already have seen in your practice. So everybody used to talk about 5 years before, resistant tinea. Then I started working, and then we realized it's not resistant tinea. What was it? It was clinical failure, because as a HIV clinician, clinical failure is very common in HIV because it's a chronic disease. So how do you know it's a clinical failure? I would like to ask one question. Any patient of tinea comes to you, start any antifungal systemic drugs. Do we get any response or no? Pardon? Initial I'm talking. Fast please, quick. Yes or no? Yes. So we did a survey across the country and we found 80%, more than 80% says when the patient comes, you start treatment, they start responding. What is the meaning of that? It's not resistant. Because if it is resistant, they will never respond any time, even if increase any dose, higher dose, for example, of hydrocortisone of 400, you give 800 milligram, it is resistant, they won't respond. So what was it? Clinical failure. So what are the causes of clinical failure? Because you are looking for the remedy. When you look for the causes, there are many causes, but one of the most common cause is lack of counseling, because most of us are busy, we do not have time to talk to the patient. Lack of counseling, and this is international also, according to international, poor adherence of the compliance because lack of counseling. And interruption therapy, giving once in a week, twice in a week, or give before 2 weeks, interruption therapy, the compliance and adherence. So we did the first study, and it been published in Indian Journal of Drug and Dermatology. Any patient comes to my clinic, we used to tell them, continue same medicine. Itraconazole, take itraconazole. We did a counseling and we found 82% of the patient, there was no recurrence, no relapse. Followed for 1 year, just for the counseling, the answer was only counseling, nothing else. So, counseling is very simple. If you want, you can take photograph of this slide. Just simple, tell them the duration, tell them other members has to be, and you get the result. These are the results after counseling. These are the patients, they responded very well. Then comes which systemic drug you should use, because we need both topical, local plus systemic. So which drug you would like to use? Anybody? Whatever the drug you are using. From the central, whatever the drug you are using, can you mention it? Itraconazole. Most of the people are writing itraconazole, but see, we need a drug which most of the people can afford. Itraconazole, how many percent of the population can afford? Terbinafine, how many percentage can afford? I started working, and then I found treatment for masses. The drug of choice is fluconazole. So does this because it was not given in the book. I started working, and what literature say, See, the bioavailability, if you see the fluconazole is 90%. Metabolism, I mentioned during the discussion, is not CYP3A4, is minimal. Tissue penetration, fluconazole can penetrate brain, can penetrate liver, anywhere, any tissue, whether it is sweating, no sweating, there is sebum, no sebum, everywhere it penetrates. Efficacy is more than itraconazole and terbinafine. Drug interaction is minimal compared to itraconazole. Resistance profile, hardly anything. So if you see all these properties, it score over all other drugs. So what we need, the drug which has to be effective or potent, has to be safe, and then has to be affordable. So we found this drug about 4 years before, and even these are the studies says itraconazole, terbinafine fails, fluconazole can be used. Even ectoderm says that itraconazole fail, you can use fluconazole. So then come to the safety. Being a HIV clinician, we use fluconazole 1200 milligram IV daily for 21 days and maintenance 400 milligram daily for 9 months to 1 year. In cryptococcal meningitis, we have used for last 30 years, it's quite safe. Then some people say itraconazole is a cardiac toxicity, QT interval. So this is one of the studies shows done in Africa, 1200 milligram fluconazole, QT interval is not affected. So don't get worried that fluconazole, itraconazole are the same. Drug-drug interaction we have already discussed. If you see, is a drug metabolism with the CYP2C19, not through CYP3A4, which is itraconazole. That's why itraconazole is with rifampicin can be given with rifampicin, warfarin, statin, you can give with any drugs. Concentration, if you see the concentration is very high. Of fluconazole is almost 11 to 40 times more than itraconazole and terbinafine. So you take any properties, it scores over, even you see the fluconazole is 23 times the highest concentration in stratum corneum. What is the target? Target is stratum corneum, not serum. So it is the highest compared to other drugs. So if you see all these character things, I think fluconazole score over, but people are not. So everybody used to ask me, all dermatology across the country, sir, where is the study? Then I approach all pharmaceuticals, and I'm thankful to FDC. They came forward, they sponsored this study, and we conducted this study. And what see, this has been published in 8,000 research. This study is fluconazole 150 mg daily for 6 to 8 weeks. Yeah, I'm not going to in detail of this study, but what is important in this study, what I'm going to show. See, we have taken patient with a comorbidity, hypertension, diabetes, hypothyroidism, combination diabetes, because most of the clinical trials are without comorbidity. I said nothing doing, we have to do comorbidity. The real patient comes to our clinic, they come with comorbidity. Then if you see, most of the study shows limited number of lesions, but if you see, 64 patients, they had extensive lesions. I said we should not compromise, you have to do the study, there should not be. Of course, scaling, erythema, pruritus, everything, the cure rate was 97%. Mycological was 100%. Then comes the adverse reaction. We did the baseline CBC, LFT serum creatinine. After 6 weeks, after 3 months, after 6 months, after 1 year, there was no side effects or untoward side effects of this drug. This drug is very safe for 6 to 8 weeks. So, this is the patient. This is the patient we started with the fluconazole with the extensive lesion. After 15 days, what happened? Everything was subsided, clinical. But after 1 month, after 1 month, patient came with recurrence. You know what is the cause? This trial we were doing in the COVID time. Can I take 3-4 minutes or? Okay. This trial was going through COVID time. So this patient went to her village, and when she came, she has stopped. The interruption of the drugs or discontinuation of the drug is the most common cause of recurrence. You'll find in a practice, if you have time, talk to the patient. After 8-week patient came, we started fluconazole and see everything was okay. Then case 2 again extensive tinea. 8 weeks, everything subsided with fluconazole 150 milligram daily. But at 10 weeks, she came with complaint of dryness, excoriation and scaling. We feel it is recurrence, but if you see carefully, there was no active lesion, erythema, active papules or something. So this was just scaling and the itching. Many patients, they come with itching, we feel is a recurrence, but it was not recurrence. We just apply moisturizer and see everything is disappear. This is another patient came after 5 visits, everything subsided. But after 10 weeks, he came with the lesions. And then from the history we found he was applying potent steroid. That is another cause. He came, we explained to him, started fluconazole, everything's settled now. Treating in this patient, this is the cardiac patient. We are talking about drug-drug reaction. This has gone under cardiac bypass. This patient, if you see the history, when any patient comes to my clinic, we write this detailed history. He has hypertension, he has got diabetes, he has got psychological problem. Which drug he give? Itraconazole, terbinafine, grisophulvin. It's a drug of choice, fluconazole. We started fluconazole because fluconazole can be given. Terbinafine cannot be given because terbinafine has got drug-drug interaction with antipsychotic drugs. So it cannot be given drug of choice of fluconazole. This is the child, he came the child, which is a drug of choice, which is the drug you would like to give. So you can give fluconazole, terbinafine, grisophulvin, but if you see the international study, the safe drug is fluconazole. Fluconazole even can be given in lactating mother, but should not be given during pregnancy. Of course, the terbinafine can be used. What should be the frequency? Because frequency of the fluconazole has to be 150 milligram daily, not once in a week or twice a week. The reason being is half-life is 24 to 32 hours, so it has to be repeated every day, otherwise you don't get result. Coming about the combination therapy, many dermatologists are writing fluconazole, grisophulvin, terbinafine together. Still they are writing. This is my neighbor dermatologist, but then, is it correct writing this? No, because when you give combination, you have increased number of pills, the cost is going on, the drug interaction is arising. So this is not, in last 4 years, we have used only one drug, but counseling. And updosing is also not required. Of course, posiconazole, voriconazole, I do not know why people write. If they are not a correct drug. See, renal failure also you can use fluconazole, like tofacitinib. Of course, the patient can't afford, multiple number of families are affected, you have to give affordable drug. And if you do not give affordable drug, 67% time there is a non-compliance. So what we are doing by giving the costly drug? So we need a drug which is effective, which is safe, and which is affordable. So according to me, fluconazole in tinea for masses, but with daily doses. Thank you very much. Any question we can take?
Thank you, Dr. Saple. Any questions?
Sir, a wonderful presentation. Just wanted to know, you see the pharmacokinetic data on fluconazole is based on, as you rightly mentioned, not on weekly doses. It's based on 50 milligram per day dose, not 150, 50 milligrams.
Initially we were discussing in a clinical trial, we should take 50 milligram, 100 milligram, 150 milligram. And there was a point, this was about 7-8 dermatology. They said, sir, you are doing wrong in 150 milligram, but if you go into literature, The dose is 3 to 5 milligram per kg body weight. You see in the literature. So we have taken it from 180, 150. Yeah, that was according to what is given in every book. 3 to 5 milligram per kg weight. Indian is almost 60 kg, on an average 60 kg. Into 3 to 5, so we take about 3. So that's why we taken 150 milligram.
But is that 3 to 5 milligram per kg body weight per day?
Pardon?
Is that 3 to 5 milligram? Because the pharmacokinetic data, I am sure it's 50 milligrams.
Yes. So I agree, but that is for candidiasis. Because MIC required for candidiasis is very low. So you can give once in a week, 50 milligram is okay. But MIC required for tinea is above 16, sometimes 32. So if you give daily, the MIC is 64. That's why fluconazole has to be given daily if you are dealing with dermatitis.
Daily for how long?
Minimum 6 to 8 weeks. If the patient is immunocompromised, is on tofacitinib, immunosuppressive drugs, they need for 3 months. 3 months. Longer duration, but not higher doses. Because I heard one of the meetings they were asking, the patient is immunocompromised, you have to increase the dose. But when the patient is immunocompromised, no need of raising the drug. I'll tell you because in 96, we studied 100 patients of tuberculosis, immunocompetent patient 50, and HIV patient 50. We have presented this in 96 Vancouver Conference, World AIDS Conference, that patient with HIV, they are less likely to develop MDR, that is resistant, while immunocompetent patient, they can develop. When the patient is immunocompromised, the organism, viruses, they can just fly in the body easily, so they respond to normal or conventional doses very easily. No need of raising the doses, but they require longer duration.
The other question is regarding, microsomal enzyme inhibition. It's also a moderate inhibitor, though it's a potent inhibitor of 9, but it's a moderate inhibitor of 3A4 as well. So it's not that it only inhibits 9, it is a potent inhibitor of 9, but it's also a moderate inhibitor of 3A4.
They said, that is a theoretical, but I am using for last 4 years, there is no problem, because I was very happy you asked that question, that this is the study, what you said. I think MSN, she's there. Kamini, where she is gone. You ask her, but what about clinical? Ultimately,
No.
hands-on experience.
Maybe, but why I'm asking this question is, for clinicians, the recommendation is, because it also inhibits, and I'm going to, it also inhibits 3A4 moderately. So therefore, would you recommend it to be used, because this would go against the package insert?
If you see,
Yeah.
it is in the literature, is the major is 2C19, major metabolism.
It's a potent and a moderate.
And minor is 2CYP3A, minor. Yeah, it is mentioned there. Yeah. We have to, but I'm using for last, how many, 30 years, we used to use 1200 milligram IV daily for, for cryptococcal meningitis. Everybody is surprised, we have managed 300 cases of cryptococcal meningitis.
Thank you, sir. Thank you for your wonderful lecture, very informative. Thank you very much. Now, I would like to invite Dr. Hidrashis Poddar for his lecture on impact of chronic dermatosis in quality of life.
बॉस रीनल ट्रांसप्लांट यूनिट मुझे फ्लूकोनाजोल बंद करने के लिए ऑर्डर दे रहे हैं, they don't allow me, they said terbinafine मैं कई बार लिखता हूँ, मैं तो it's my favorite drug, वो very rich, सब ठीक हो जाएगा।
You allow me, do you have time? No, you visit the renal transplant unit of BHU. We had a discussion with them. I had a long discussion with them. Pardon? No, fluconazole can be.
Very good afternoon.
You visit the renal transplant unit of BHU.
Thank you to the organizers for giving me this opportunity. This talk is mainly whatever the previous speaker has already said, something about impact. This is not only about tinea, but
Yes, itaconazole. I'm talking fluconazole.
okay. So this is all about chronic dermatosis and the quality of life. So this is my conflict of interest slide. Nothing to declare. So what I would like to focus is that this is a very important aspect in today, and we need to highlight that and we need to address that in all our patients. So this is just what is quality of life. I have just boldened those portions. That is an individual perception. So quality of life doesn't have some known set parameters. There is an individual perception of each patient that is different, and in the context of culture and value systems in which they live, we cannot expect the same quality of life maybe in the Western countries to reciprocate that in our system. So that should be individualized, and for that detailed patient history is of utmost importance. It can be of population or individual, but we don't go into that. This is mainly physical and psychosocial well-being. So both are important. Physical well-being, of course, we are dealing with the drugs, but psychosocial well-being is something which is the topic of discussion. And there are multiple components of QOL, which we will also see later. And sometimes they can be divided into domains. Like we know some scales, there are some domain distribution for deeper understanding. These are, in my opinion, the prime components of quality of life in our practice. So one of the very important aspects are the psychiatric morbidities like depression, anxiety, stress, mood disorders, all of this. Next is work absenteeism, work presenteeism. This is important. Work absenteeism means for how many days the person is not being able to go to work. That can be for any chronic disease. We'll just show what disease is. And work presenteeism means the person is going to work, but he is not able to work adequately to his capacity. And sleep disturbances, sexual dysfunction, important. Sexual dysfunction is very, very poorly addressed. And societal burden, this is also important. How much economic burden it falls on the society, because the person is not going to work, so there is some amount of revenue loss. And the society also has to spend for the patient, like we are ordering investigations which are free of cost in a government hospital. Many places they are getting the medicines. So in this way, that creates a societal economic burden. So these are all the different aspects. Now, what are the this is very important, that how to measure QOL, because as I said, you need to have a history is very important. So there are some patient reported outcome measures, very important, very crucial. So they can be of two types, generic and disease specific. As you can understand, generic ones are for all dermatological disorders, and they take shorter time, but they are more broad. Disease specific prompts, we'll see what are they, but they're more sensitive, but they're more time consuming. So they're difficult to do in a busy OPD. So these are some of the commonly used prompts. You can see generic prompts, we are all using DLQI, I'm sure. Then FDLQI is family DLQI, and then child DLQI. VAS is visual analog scale, Skindex, HADS. These are, I'm not reading out the scales, you can see them. And disease specific prompts you can also see for urticaria, psoriasis, vitiligo. Acne has got a lot of scales to that. Even there are scales for acne scars, for hand eczema, and leprosy has also got a scale, but it's still under validation. This is just the DLQI scale, and this is the interpretation. Interpretation is also equally important, because if you are not aware of the interpretation, then you can't assess that what is the quality of life of that person. These are some of the chronic disorders which impact the quality of life heavily. There are many more, but this I think have maximum evidence. Psoriasis, vitiligo, acne, hand eczema, atopic dermatitis, urticaria, leprosy, very important, and hidradenitis suppurativa, and many more. What I will do in the next section is that I will try to show you some evidence about the impact of these disorders on quality of life. Psoriasis, as you can see, this is a systematic review. You can see the DLQI score. I have also given in the insert. So you can see it's more than 10. That means a very large effect. And you can see the different sites and their impact on quality of life. This is another review which says that even nail psoriasis, which is very, sometimes it remains undetected and we often ignore, but that can also impact the quality of life. This is another study which says that all of these are interrelated, the different components which we all showed, sleep disorders, quality of life, so decreased productivity. So all of these components, they are actually interrelated to have the overall quality of life of the patients. Vitiligo, again, a very interesting study. They are from multi-country study, and you can see the scores. It's highest for Saudi Arabia. It's almost 14. So a very large impact on the quality of life. And this is about the child DLQI score. Even there you can see that it's pretty much depressed. It's maximum depressed in Turkey, but this depends on the number of studies. But overall, vitiligo is a disease which, as you can understand, impacts the quality of life. This is another study which says that vitiligo, you can see the chart here which I have given, and you can see the facial lesions, of course, and it's understandable that they will, and you can see, and even body surface area is affected more. So the highlight is that vitiligo is one disease which definitely impairs the quality of life. Acne, again another, you can see these are the different components of the DLQI questionnaire. So the total score is 3, and you can see how badly it is affected, and it's more affected if patients have both facial and frontal acne compared to facial acne alone. This is what I was talking about, that atrophic acne scars. So acne is very interesting because with other diseases except vitiligo, only the active disease has got some impact. But for acne, maybe the acne has healed, but there are scars. That will also have a very large effect on the quality of life. Hand eczema, a very chronic disease. Now it's said that any eczema more than 3 months has to be said as chronic eczema. So that can also affect the quality of life. Atopic dermatitis, as it's clearly understandable, that can affect the children's quality of life. And this is something which comparison was done. Chronic urticaria is also again another chronic disease which see that multiple components are anxiety, depression, almost 30% patients present with psychiatric morbidities, and they can be also responsible for sleep disorders, sexual dysfunction, some of the lesser highlighted points. These are another studies on chronic urticaria which say that it is affected. And now I'll just, the final portion, that are there any predictors? This study was done, type D personality. So there are questionnaires for this. So what we can do is, we can try to assess the personality of the patient, and if a person is found to have type D personality, then possibly he or she is at a higher risk for having a greater impact on quality of life. Leprosy patients, they also have an impact. You can understand with all deformities, they are definitely going to have a quality of life impact. HS is of course a very chronic recurrent disease, and you can see these charts, the colors are not so clear, but you can see the average is more than 10, it's in fact more than 14. So very large impact on quality of life, both in adults and in children. Now, sexual dysfunction is also impaired. As I said, we seldom assess sexual dysfunction, but this is important. This review was on atopic dermatitis, but they compared it with other disorders like HS, lichen simplex, vitiligo, chronic urticaria. Now, this is again very interesting. Why I will say, because this not only affects the patient, this will also affect the patient's partner. So maybe the patient's partner is healthy, but his or her sexual life is impaired. So this is something you have to keep in mind. Even in children, it's affected. We have the children DLQI score, and it has been found that atopic dermatitis, acne, molluscum are the diseases with maximum impact. Now, this is what I was telling, that it is not only restricted to the patients themselves. The caregivers are also affected. Like in this case, parental stress and chronic childhood dermatosis. The thing is that if parental quality of life is hampered, or if caregiver quality of life is hampered, then the care for that patient will not be optimum. So whatever treatment you give, whatever counseling you do to the patient, that will not be of optimum use. Now, not only chronic dermatosis, my previous speaker was also saying, so this is something we saw, that even in chronic recurrent dermatophytosis, they are also having symptoms of depression and anxiety. And this was a study which we published also. So it's not only restricted to chronic diseases, it can also be for infective disorders which become chronic and recurrent. So this is my last slide. We have all gone through this, that quality of life is an important aspect of patient health, which we must address in every patient. This is important for the overall and holistic disease control. We have generic prompts and we have disease-specific prompts. Validation of promises written in local language is very important, because otherwise you won't be able to get to your patients appropriately. And there are several dermatoses which I've all discussed, which can impact the quality of life. Some lesser discussed what I should say, aspects of quality of life need more investigation, like sexual dysfunction, work impairment, societal economic burden. Even children can be affected, and not only children, as I said, it's not only the patients, their caregivers or partners can also be affected, even if they're healthy. And that will, in a way, like a vicious cycle, it also hampers the quality for the patient. And not only chronic diseases, even acute diseases with a chronic and recurrent course can also impair the quality of life. So that's all from my side. Thank you for your patient hearing.
Thank you, Dr. Indrajish. Any questions?
Yeah, very important question. Because I did a study many years back in the early 90s, quality of life and catecholamines. In the segmental vitiligo, there was a high catecholamines, and it was directly related to quality of life. They are all diseases, if you see, psychiatric disorders, depression, catecholamines. But I think catecholamines in vitiligo has been published years back. Now there is a review, international review on catecholamines and quality of life. Kindly read it and you tell me.
Yeah, sure. So that's like more into going into the background of why this impairment is taking. So that's very interesting. We can definitely take it up.
Thank you, Dr. Indrajish. Now I would like to request Dr. Rashid Shahid to talk on RFA in vascular lesions.
Good evening, everyone. Today I will be speaking on interlesional radiofrequency in vascular malformation. Now, vascular malformation, it presents at birth and do not proliferate or involute. And further, it is categorized into low flow and high flow. Low flow in that capillary, venous, lymphatic, or combined is covered. And in high flow, there are arteriovenous malformation. Out of all the vascular malformations, roughly 70% are venous. They are soft, compressible, non-pulsatile, mass of variable sizes. They can present as isolated skin varicosities or ischemia, localized spongy masses, or a complex lesions that infiltrate various tissues, planes such as muscles. Lesions are common in the head and neck, particularly in the lips and cheeks. Most venous malformations are asymptomatic and can be managed conservatively, but symptomatic lesions and those that cause cosmetic deformities require treatment. As the boundary of the venous malformation is not clear, the curative effect of surgical resections are limited and relapse is relatively common. Treatment in the form of vascular laser, sclerotherapy, resection is needed only if lesions present these symptoms and or cosmetically deformity is present. It is usually impossible to excise the lesions without complications. The surgery involves interventional procedures, and the vascular laser is not available everywhere in all the institutes or hospitals. So interlesional RFA is one of the cheapest option and safest. And radiofrequency ablation is minimal invasive procedure with minimal or no scar. And here we are discussing how interlesional RFA is useful when other modalities are not available, failed, or not possible. Now, before doing interlesional RFA, we have to do a proper counseling to the patient with respect to procedures results aimed to achieved, and possible complications. RFA is contraindicated in pacemaker and keloid tendency, and also if patient is taking aspirin, it should be stopped 3 days before the procedure. If patient has developed herpes labialis, a cyclovir should be started on a day before surgery and should be continued for 1 week, and informed consent should be taken from the patient before the procedure. Intralesional RFA can be done with 18 gauge needle with local anesthesia. Metallic part of the cannula is used. The metallic part of the cannula is used as an extended probe to deliver RFA energy selectively into the cavity of venous malformation, and the plastic over the needle works as an insulating agent. In a modified cannula, a small nick is made on the proximal part of the plastic strip to expose the metal part so that the direct contact could be established between the probe and needle for conduction of RF current, as shown in this picture. Now coming to a few cases. This is a 22 years old female patient presented with venous malformation over the lower lip. Since 10 years, it was asymptomatic, but it was gradually progressive. And we did RFA in this patient, and 4 times over 6 months. So as the cannula is inserted inside the venous malformation, and the RFA probe is touched on the needle, cannula metallic portion to deliver the current. This is the baseline photo, and after 4 sessions over 6 months, there was drastic improvement in venous malformation. Another case, a 28 years old female with a history of vascular malformation over the lower lip since last 2 years, which was asymptomatic, but it was gradually progressive. So we did intralesional RFA in this patient as well. See the reduction in vascular malformation after a single setting. This is another case, a 26 years old female with vascular malformation over the upper eyelid since last 6 years. It was gradually progressive and asymptomatic. So we did intralesional RFA. See the reduction of size of vascular malformation after single session. So to summarize, intralesional RFA is a simple method to treat vascular malformation with no complications, and it does not require any special expertise, and it can be done anywhere with resourceful setting. It is a very cost effective and there is a good response cosmetically with minimal to no scar. And while doing intralesional RFA, we have to keep in mind about take history about the pacemaker and also keloidal tendency to the patient. I would like to acknowledge Dr. Satyana ma'am. Thank you.
Any questions?
Yeah, just a couple of comments. Firstly, radio frequency. Yeah, Manas Chatterjee.
Yes.
So if you can get asynchronous spacing, that will not affect your radio frequency. That's one. Otherwise, there are 2-3 methods of using RF. One is if you're using bipolar will not be affected. So that is one. Second is if you use short bursts and lower power, and do not be anywhere near. For example, these cases you are not near a pacemaker. So a pacemaker itself is not a contraindication.
Okay, thank you.
Thank you. Thank you, Dr. Shahid. I think that ends the session.
Thank you all the faculties for the session. Now I request Dr. C.S. Irkasa to kindly felicitate our faculties. Achha, sorry. For the moving our next session, I request Dr. Tulika and Dr. Rasmi to kindly come onto the stage and chair the session.
Yes, sir.
Now I would like to invite Dr. C.S. Sarga sir for the next topic, that is challenges of aesthetic dermatologists in the 21st century.
Thank you, madam. Respected audience and my dear friends. What I saw is during this year, the change is inevitable. Like now, if you see in picture on the left side where I was born, and currently like now I stay in a house which is on the right side of mine, that what you can see. But if you register any change, it is always painful. You all must remember. So one has to move with the time and move with the changes that do occur. And if you don't, then it could be painful for you. Today my topic is challenges for aesthetic dermatologists in 21st century. I felt better life will allow like no artificial intelligence use, especially in India. It will allow more and more. Better life will increase the incidence of an atopic dermatitis through the hygiene hypothesis. It has been told that if you have a better hygiene, then you are going to have more of an atopic. Invariant effect of an atopic dermatitis, then it will cause a widespread infection, because all infection requires an abnormal skin for a penetration to cause a disease. Cutaneous trauma on atopic dermatitis may evoke a development of a post-traumatic eczema. This is a relatively new term, but it has come up a long back. Only one thing is that like we are not very familiar with this particular term, the post-traumatic eczema. Artificial use in India will increase the incidence of a self-medication and alter the environmental microbiome, because it will kill the organism, but it will not kill the virus, because the virus stays in the dorsal root ganglia. So it could be quite possible that with the passage of time you are going to see that there is an alteration in the environmental microbiome and you will have a change. Next one is an increased incidence of an atopic dermatitis and altered environmental microbiome will result in a new challenges, because you have never seen those challenges, and the challenges could be a real challenge for you to deal with them. Now, when you deal with aesthetic dermatologists, basically we deal with the destruction or a damage to the skin surface. So, my focus will, if you induce a cutaneous trauma in 21st century in an environment of a changed microbiome, what is the possibility that you will come across? So I will be trying to focus my talk entirely on that one. Like trauma by a better life. I mean to say the better life is, if you stay in a better life, you are going to use AC, you are going to use a room heater, you are going to use a fan. Then there is one chance that you are going to have is, there is an increased incidence of an atopic dermatitis, and this atopic dermatitis could have a very severe form, which you can see in this picture, that like now, this patient of an atopic dermatitis, in every fold, he has an increased disease of an atopic dermatitis presenting as a pigmentation, what you call it an acanthosis nigricans. This trauma is because of the body fold and a constant flexion and an extension, and that can mimic like a acanthosis nigricans, but this is, I believe, it could be a part of an atopic dermatitis. This is already known that like now, if you have a better hygiene, you are going to have an increased incidence of an atopic dermatitis as well as an increased incidence of an severity of the disease in atopic dermatitis. It is also very well known that the patients of an atopic dermatitis will have an increased incidence of a post-traumatic eczema. In an atopic dermatitis, either a surgery or any disease causing a trauma could induce a post-traumatic eczema. This is not a very old one. If you see the left side, that's an old classification. If you see the new classification, it has come on the surface that there is an entity like the post-traumatic eczema exists. Atopic dermatitis patients came to my OPD. I ordered for a prurigo nodularis that the patient can be given a Kenacort intralesional. By mistake, our resident gave it on the cheek. The patient was having an acanthosis nigricans like changes on this thing. You can see there is a significant change. There is a change in the texture, change in the color. This is the original photo of this patient, because there is a teaching to our resident is that if they do some procedure, they do have to take the photograph. Then I asked them that do another mistake again, because you did the first time and you should do it again so that we get an improvement. Now the patient is extremely happy. We give an intralesional at a distance of 1 centimeter apart with an insulin rate 4 to 5 marks of that one. Because now we tend to believe that the acanthosis nigricans on the face or a forehead could be a part of an atopic dermatitis. We also believe the severity of the disease could be more in 21st century because of the hygiene hypothesis. Now I do see that some of the patients, they look like a bullous pemphigoid because they do have a massive erythema along with the papillary lesion. My voice told that no, it is a bullous pemphigoid. I just asked them, can you count the number of bulla in this patient? They could never show me that no, they are bulla. Then I told them, why not? This is only a pemphigus. They said, no, it cannot be. So I tell you that no, in a 21st century, it could probably confuse you. A severe form of an atopic dermatitis presenting with an erythema and edema could be a other dermatosis. You should be careful about that one. This is also another patient where we made a diagnosis, this one. When we asked these patients carefully, he said the first episode was not an erythema or not a hemorrhagic crust. This is the second episode which has got a hemorrhagic crust. We made a diagnosis, probably an atopic dermatitis superimposed with herpes simplex infection, what we call it a Kaposi varicella eruption. This is not a very thing now. Recently we came across the article written by Arora et al. The severity and the duration of a trauma on skin can be responsible for producing a frictional dermatitis, what we call is a post-traumatic eczema, and it entirely depends on the severity and the frequency, duration of the trauma. I strongly believe that any trauma on the surface of atopic skin is going to give some changes of atopic dermatitis. It can present that, if you can see, there is a micro trauma on the surface of the finger could be causing an eczema. And if you have a tinea for a prolonged period in atopic dermatitis patients, you are going to have a post-traumatic eczema. You see this lady, she's wearing a sari and having an atopic dermatitis because constant friction, she has developed a post-traumatic eczema. And there are some of the few pictures where it shows that these people have been using a face wash or a scrub which has given rise to a post-traumatic eczema and then pigmentation. And you can see on the right, extreme right, the patient had a trauma followed by an infection on that particular area by the tinea, and tinea has healed. Now that particular area, the patient has left a post-traumatic eczema. You can see these are some of the examples. Wherever the friction would be more, you are going to have a post-traumatic eczema. This is also the last circle shows it is an initial tinea but when there is a recurrence, the trauma became double in those areas and the patient has developed all lignified changes. Factors aggravating atopy and the possible change that can occur. If you have an atopic dermatitis, the first thing, the environment change can give rise to the severity of an atopic dermatitis. And if you have a change, artificially if you are changing the environment, then also you are going to have an aggravation of an atopic dermatitis. And if you have an atopic dermatitis, you are going to have a very peculiar infection. That is like, there is a multiple opening on the surface of the skin because of the variant defect, and you are going to have a bacterial infection in a large number of places, because you are auto-inoculation in a process of scratching from one place to another. If you have a tinea, then the trauma could induce a post-traumatic eczema. If you have a herpes, there is a possibility that you are going to have a recurrence also. It is not necessarily that you need to have an immunosuppression. Even the normal course of relapsing and remission of an atopic dermatitis also can give rise to a recurrence, that what you can see the photograph shows. And this is what example which you can see, that the lady has put a thread on the arm, somebody has scratched, and somebody has this thing. So all of them, even I have seen that even psoriasis could induce a post-traumatic eczema at the psoriasis site, where it would be very much prominent because they will have an increased lines, the suggestive of an eczema, LSC. So this is how you can have a large number of changes if you have an atopic dermatitis and if you are using this one. And it is likely that you will use all this because there is a changing lifestyle of yours will allow you to do all this work. This is not a new one what I am talking. Already some people have spoken that if you have a fungus in atopic dermatitis patient, there is likely chance of a development of an atopic, post-traumatic eczema in a tinea site, and its remission and relapse can also confuse you because it will go, come, the severity will go and come. If you have atopic dermatitis and infection, what would happen? If you have atopic, there are 3-4 things that do occur. There is a shift in the T has can prolong the disease course. If you have a variant defect, you can have a widespread fungal infection because there are multiple sites. Fungal arthrochonidia can bind and it can induce a fungal infection. And if you are having an atopic dermatitis, wearing a tight dress, there is a possibility that you are inducing a trauma. In that trauma, you might induce a large number of fungus to make an entry, and you can have an increased predilection of the fungal infection in those sites. If you have an atopic dermatitis, the fungus itself can induce a post-traumatic eczema. You can have this one. And if you have a post-traumatic eczema, they can run through a chronic remission and relapses. So in atopic dermatitis with fungus, if you have a disease, you might have a fungal infection, you might have other dermatosis. You do have to really recognize them. Otherwise, you might go wrong. And you believe that your antifungal drug is not working. So you have to be clinically good to identify what you are dealing with. What causes widespread HIV infections? Because I told that something like HIV also becomes a lesson. Now my belief is certainly is that when you have an abnormal skin, especially like an atopic dermatitis, the herpes can involve the contiguous keratinocytes which attach to the another dorsal root ganglion. So reverse movement can involve the entire ganglion of the spinal cord, can have an involvement with the herpes simplex with the passage of time. So it is likely that besides having the lesion on the lips and genitalia, now you all have to think that the herpes can occur in almost the entire part of the body area wherever you touch. We'll show you some of the pictures that will help you. Because these are the situations where it says the prolonged variant defect can trigger an HSP because it can have a recurrent one. If you have a recurrent one, it might have a contiguous spread of an infection and involve the entire dorsal root ganglion. Sometimes the HSV can induce an immunological vasculitis. It is already known. It is already known. It's not a new. That there are some articles which do say that it can cause, and during the episode it can involve the immunological vasculitis and give rise to massive bleeding or a bleeding on those sides. That is why sometimes you might see that the herpes infection can have hemorrhagic lesions, and you are confused for something, maybe that he does have a hematological disorders that is causing in that one. Cutaneous trauma in HSV infected patients in 21st century. In an HSV infected patient, how it can have? You can have the situation like this. Either the atopic dermatitis can trigger a herpes simplex infection, and the herpes simplex infection, an immunological disturbance can give rise to a HSV vasculitis. Atopic dermatitis having an abnormal skin also can give a contiguous spread. That will give a reticulated lesion. That you can see that the lines are linear erosions, and repeated episodes of an atopic dermatitis can have a recurrence. That can also give rise to, you can see that the multiple erosions of a different states are visible on this one if you have a close-up look. Now you are going to have, I told that you might have a dorsal root ganglion is involved. If you do a surgery, especially the aesthetic dermatologists, if they are doing anything, you might have this kind of challenges. That suddenly the donor area might have a herpes infection, and you can see the multiple circular erosion with an hemorrhage on the surface. So it can delay your healing. We had a patient who had a road traffic accident. After 7 days, we could see that the patient is getting a large blister filled with a hemorrhage. That is why you could see the different shades of a color in a same patient. Some of the lesions have become a necrotic, because there is an ischemic necrosis is also possible when you have a HSV vasculitis. This is how you can have a whole gamut of picture if you have a HSV infection. So one has to be a very much clinically sound to know what is happening. Otherwise, you made a diagnosis and you are thinking it could be possible.
We are running short of time.
Okay. I think so we can wind it up. I will tell you that if you have the herpes simplex infection and atopic dermatitis, you are going to have a huge challenges. So you have to be carefully in this direction. Thank you very much.
Thank you, sir, for an interesting talk. Thank you, chairpersons and our speaker for the session. Now, I request Dr. R.N. Datta sir to kindly felicitate the speakers and the chairpersons. We'll move on to our next session, that is Professor Dr. Amar Khan Jha Amar Memorial Oration.
हाँ अब आ रहा है हाँ छोटे भाई बता रहे
So, Professor Dr. Amar Khan Jha Amar was born on 21st June 1949 in a small village of Bihar. Then after completing his MBBS from DMCS Darbhanga, he completed his MD from PMCS Patna. And in 1997, he became the first person of Bihar to do PhD in dermatology. He has served more than 34 years as UG and PG teachers and guided more than 140 PG students. He served at HOD Dermatology Department of PMCS Patna, Superintendent, Principal and Dean of Faculty of Medicine, PMCS Patna. He was awarded many awards, but the most promising were Guinness Book World Record, Lifetime Achievement Award by AD and AJD, IADBL Glasgow Oration, IADBL Best Teachers Award. He has published more than 100 articles in national and international journals, contributed 3 chapters in dermatology textbook. He served almost all the posts of state branch of IADBL and in the state journal conferences. Not only state, he also served and contributed national IADBL as honorary general secretary 2 terms, national vice president and member of constitution committee, and IADBL CC members in 1987. He was also organizing secretary of Dhamaka 1991. As an able IADBL member, he almost attended all the conferences, meeting and prepared IADBL National Directory, increased the membership drive during his tenure. The National IADBL program, IADBL Chala Gaon Ki Aur, is brainchild of Professor Amar Khan Jha Amar. With a long time serving of IADBL light, with due advancing stage, he still as a dedicated IADBL member. We still remember, he is no more, but as the name is Amar. So this time, Professor Amar Khan Jha Amar oration is conferred to Dr. Professor P.K. Roy sir. Sir, I kindly request Professor Roy sir to kindly deliver the oration.
Mike.
जगे हुए हो सोए हुए बिफोर आई स्टार्ट आज विजय दिवस की आप सबको हार्दिक शुभकामनाएं। टुडे विजय दिवस फौजी हमारा बैठा हुआ है तो आप सबको हार्दिक एक्स फौजी मैं भी हूँ। सो द जर्नी इज द ब्रीफ स्टॉल, प्लीज कम along. The moment I was given, I was outside India and I came back on 6th or 7th. Then I was told that I have to give this oration. Why me? समझ में नहीं आया, because I am not Tom Holland. I don't have any rage around me. You know, there's a rage word which I invented this year and is the most used word this year. It means that there is nothing remarkable about this person. So I have no rage. But then Dr. Datta and Dr. Abhishek said that you have been chosen for this. So let us start the journey. I'm trying to take you along in very brief time. My initial education was in a school which later on I termed as St. Boris School. But before I start my journey, मेरे गुरु को मेरा प्रणाम, जिन्होंने डर्मेटोलॉजी में मुझे ज्ञान सबसे पहले दिया, प्रोफेसर डॉक्टर गुरमोहन सिंह। प्लीज गिव इट बैक। हमारे सबसे पहले गुरु वही थे, उनके बिना वंदना किए मैं आगे नहीं बढ़ सकता हूँ। So it was St. Boris School. I mean, in every town in Bihar, and there is a small pond. This is called Pokhar. And there is a very small school situated on the bank of the Pokhar. We used to call it Pokharia School. And this Pokharia School has its own, you have to take your own sack to sit on the floor. Bora samajhte hoge? So when I went into Metro College, when I met friends from there, some Sanjay, some whatever naam hote the, so I used to feel very guilty about it. Then I said, nahi, my primary institution was in St. Boris School, Boris for Bora. Then next I went to, this is my primary education, primary and middle school education. I'm an academy lad, very famous school. And the principal was 3 times President's awardee, Dr. Jaygur Sola. Very fond of beating the students with the biggest stick. I also had my opportunity to have that blessing from him. Hello. And that time, in class 8, it was destined that you have to become a doctor, you have to become something else. So in class 8, I chose biology, and that's why I'm here today. Next was CM Science College, where I did my pre-university that time. And then my quite good journey started in Darbhanga Medical College, ASY. And this audition, जिनके नाम से याद दिया जा रहा है मुझे डॉक्टर अमरकांत झा अमर, he was my batchmate. 70 में we joined together Darbhanga Medical College. We stayed for 7 to 8 years together, and we are very good friends. So मैं अपने को I'm acting very. I thought he is talking to me. बहुत गर्वान्वित महसूस कर रहा हूँ कि this evolution has been given to me and all. These are some of the quotations. I don't like to go that, but then memory reminds us that nothing lasts forever. Time is precious and should not be wasted. Enjoy life and remember. Don't count the days, make the days count. 7 years in Darbhanga Medical College, it gave me my degree, it gave me my friends, like Amarkant and many others, and also I met my wife and married her when I was in medical college. Tribute to my closest friend, as the name goes, Dr. Amarkant Jha Amar. He is Amar. Some of the photographs with him. On every occasion, starting from my journey in 1986 in the dermatology department in Patna Medical College, I have been with Amarkant Jha in one way or another throughout his journey and our journey in dermatology. Unfortunately, he left us 2 years back. But before that, we are thin and thick together in every thing we did. In IAD, we have conferences, awards, this and that. After my graduation, I joined Army. In 77 to 83, I was in Army. There are some of the photographs of my Army, where from a middle class person to an Army person, it changed my perspective of life. It gave me some kind of discipline, some kind of being a human being, being a good person. And cultivating that discipline in Army, I carried out throughout. It is still there with me. And when I became a teacher, instead of teaching the students the bookish language, I used to teach them, be disciplinarian, discipline ka palan karo, apne samay karo, be honest to your patients. So that's what Army gave it to me. Back to medical college from Army, I came back to Bihar Medical Services, and my first appointment in Bihar Medical Services was in the leprosy hospital in Rambe, and that's how I was interested in dermatology. You see the leprosy patients there. The first time I was seeing a leprosy patient and doing the gene lens and seeing their deformities and all, it moved me a lot. But that got me interested in dermatology, and I did dermatology as you see today, the young generation. That was not then. Right now, I think that for taking a dermatology and PG, you people pay about, people pay, not you people, but people who are opting for dermatology, they pay hefty sum of money to the department. Maybe it is being sold in 1 crore or rupees or 50 lakhs or something. That time it was not so. That time the Bihar government wanted me to come and you gave me money. I was appointed in the leprosy department as PG resident with full pay. That was there. So 86, I joined back Patna Medical College as a PG resident, and then it was a roller coaster from there. In 88, and Professor Gurmohan Singh was my first teacher there. He used to come as an examiner to the PMCH every year. From 74 onwards, he was coming regularly to the department. That's why I came to know him, because I was escort there when we used to come to examination. My professor, late Dr. P.K. Sinha. Since I was an army person, I saw that no better person than him to serve this eminent personality here. So I was assigned task to looking after him whenever he came to Patna. And that's why I became a disciple of Professor Dr. Gurmohan Singh. After doing my degree, I was in Bihar government state service for 8 years, doing something or other, like a skin specialist and all. Then I became registrar of the department in dermatology, going through assistant professor, associate professor, and retired professor and HOD of Nalanda Medical College, dermatology. Journey, Bihar government, any government service like you feel, it is ups and downs. You have to fight for your rights. Nobody was appointing me as a registrar because there was a huge fight between me and another person. And the casteism was in full form in Bihar. So I had to fight my way to become a registrar there. And then after that, I had an easy life because assistant professor, it was by promotion, became assistant professor, associate professor, and finally as a professor. When I became professor, I was transferred to Nalanda Medical College and HOD. And I retired from there in 3 years back, and then again on extension, I served there at 1970. Then ideal journey I started in 88 when the Bihar Criticon was there, and where I had the fortune to meet Srinivasan is not there. He came as a speaker there. That was also, I think, his first conference. He came as a speaker, I met him there, and then we were friends. But my real journey started in 90 in Jaipur conference. So I met this eminent personality, Dr. Dinesh Mathur. I was novice. I went there just like that, became a delegate, registered myself. There was a faculty meeting, this CC meeting going on in 90. I went there because I didn't have any room to stay on. So I went there. I saw a big fight going on. So I was wondering, did dermatologists do this? They keep on fighting. There's a big issue, something. In the evening, there was a faculty dinner. I was not invited because I didn't have any room. So I went there. Somebody told me, you meet Dr. Dinesh Mathur. Very humbly I went to him, sir, मेरे को room नहीं है, एक room दे दो क्या आज आजादी के लिए. रात में क्यों तो रहो. He gave me a check, go to that hotel, and I'm still thankful for that. He taught me, he is such a soft personality, taught me so many things, and from then on, I'm a big fan of Dr. Dinesh Mathur.
Thank you.
He started in 90, and then second milestone came when in 92, that is something. We had this national conference right in corner, that IADL national conference. That time it was not known as DermaCon. These con things were not there. We were not conned into coming into. I still don't like that name. Don't worry about that. It was IADL national conference, 20th IADL national conference in Patna, 92. First time we hosted it. First time I worked for it. And by all means, I mean, like what Professor Saab and everybody who attended, they said that it was a very good conference. I don't know, I can't praise myself. But we tried to give the big hug. And Biharis are known for their good hospitality. So we gave everything to that conference. And then my journey really started in IABUL when people started knowing me, that he is Dr. P.K. Roy. And he was the treasurer of that, and I was the treasurer of Bihar, this IABUL Bihar also. So I started making friends. And in IABUL journey, got a smoother from there on. I have met many friends here. All of them are Professor Datta. ये उन्हीं को दिया था सम्मान. I hope he is not reciprocating me that. You remember that? Professor Datta came as an examiner in NMCH. He was as a NMC observer to grant PG degree, a PG residency to NMCH. And he was not very keen on giving that. That time only there were 3 medical colleges around with PGD. Right now there is only 2. So he was not very keen. कि ना standard बहुत घटिया है, मत करो, मत नहीं देंगे एक मीटिंग में. मैंने कहा शुरू तो करो. बना तो हम लोग देंगे, पहले शुरू तो करो ना. But he was kind enough to start one PG seat. He allotted one PG seat to Nalanda Medical College that year. And now there are 4. For your knowledge, sir, there are 4 medical PG residents in Nalanda Medical College. They are doing very good. Their place is very good. And thank you for that. These are all the conferences we have done in Patna, honoring Dr. Saidanand. They are very good friends of mine. All the Institute Derma Jones we had there. So it was a very good journey, holding conferences and all. Almost all conferences held in Bihar, I was somehow associated with that. And I'm still associated with that. I have a very good next generation. Dr. Abhishek Jha is not here. Dr. Amar Kanja's son. They are the new generation who are taking Bihar IIT to new heights. You know, remember, when I started my journey in Bihar IIT, there was only about 11 delegates, 11 members, IIT members. Only 11. By the time I left, there were about 200, 300 members. But then Jharkhand got separated and half our members went there. So they still have over 200. And 1992, आज के दिन में जो मेला लगता है आपका डर्मा कॉन 5,000 delegates. That time I only had 600 delegates in 1992. So I could look after them. These are some of the photographs. Then we have this IIT will chala gaon ki or which Athena has mentioned, Dr. Amar Khan has brainchild. Every month he used to go to some village to do this medical camp and all. It was when Venkatram was president, he took it as a national program. But somehow or other it got fizzled out later on because he wanted to increase the para of this thing. I will chala gaon ki or become I will chala apno ki bhi, then I will chala something. And then it got, it's still there. In Bihar, we are still having Idol Chala Gaon Ki Or. Every month, some team or other goes to a village and does this camp. We have seen all these photographs. I'm going back. I should go forward. Then what happens when you ask a live person like me to do an audition? From the very beginning, I saw my friends going higher and higher and everywhere. People achieving so many things. In any conference, they are giving audition, this and that. And I used to wonder what they have. But then, I said, I'm not in competition with anybody but myself. And my goal was to improve myself. This was my last slide before I start. It was a very beautiful journey. And dermatology, for the young aspirants here, dermatology is not the clinical dermatology it used to be. It is a very good opportunity for you. We had cosmetic dermatology, we have dermatosurgery and the latest aesthetics. And that's why I think it becomes so powerful brand that we can spend 1 crore rupees to enter this. But one thing I would like to say, but don't forget to clinical dermatology. 3 years you give to do, and out of 3 years of dermatology, PG, you have 2 years to clinical dermatology, and last 1 year you keep for company. That's my advice. Because unless you are strong in clinical dermatology, you can't become a good dermatosurgeon, you can't become a good cosmetic. So my last request will be, and my last slide will be, here walk us. In this long journey, thanks to the people who have walked into my life and made it very beautiful. Second line is not, it's not concerning you people, but it is for the people. The thanks to the people, they came into my life and walked out, and that's why they made it more amazing. Thank you very much. Thank you to the organizers for giving this opportunity. This journey was beautiful. Dermatology is a beautiful subject. And मैं अभी भी इस बात से बहुत चिढ़ता हूँ. Even when I joined, my friends used to say, चमड़ी का डॉक्टर अच्छा है, this is good. चमड़ी का बीमार कभी ठीक नहीं होता है, कभी इमरजेंसी नहीं होती, बहुत लाइट. I mean this, and when I joined dermatology, my own uncle, he used to say, कहाँ जा रहे हो? that चमड़ी का डॉक्टर बनने जा रहे हो. But now you see, this dermatology, first choice of PG is dermatology. So this journey has been beautiful for making from there to there. And now everywhere you are respected as a dermatologist. You are not being looked down upon. Thank you to people like Professor here, Dinesh Mathur, Datta, Sirka, Manas. They have made it beautiful. The dermatology is being talked about now for these people. Thank you. बंद करो आराम से। अच्छा इसमें मानस इसमें बैठने में बहुत डर लगता है।
साइड से ना भाभी,
He is a jolly good fellow. He is a jolly good fellow.
भाभी, भाभी,
भाभी,
ए भाभी, भाभी, साइड से, साइड।
अच्छा आपको पहना है तो पगड़ी ना भूल जानते हो, अगली बार से रखना। थैंक यू।
बेल्जियम वाला भी होगा ना? हाँ। अभी मोबाइल पे भाई मुबारक है।
मुबारक है आपको भी मुबारक। मैंने आपका नाम ले लिया।
Moving on, next we have Ratindranath Datta Memorial Oration. Rabindranath Datta Memorial Oration. Late Rabindranath Datta, the son of Gopal Chandra Datta, was born in Jessore district in undivided India, now Bangladesh, around the time Lord Curzon partitioned Bengal. Though born in a rich farmer family, he being adventurous in nature and left his home and came to Jamshedpur at a time when the Tatars were concentrating in steel production of our country. His passion for adventure made him to join the Royal Indian Army, and thus he travelled throughout the Middle East during the Second World War. Seeing the plight of common Indians and after a near fatal accident in Delhi, he decided to retire from army and help his own people. Back in Jamshedpur, he joined Telco and started helping others, sometimes at cost of his family and friends. He earned deep respect from all around him. He avoided publicity as he felt that pride might set in and hamper his noble work. Till the end, he led a simple and frugal life. In his last sedentary years, he would continue giving valuable advice to those who would meet him to improve themselves. A social worker, a nationalist, and a visionary, Rabindranath Datta left for his heavenly abode in May 2007 in Jamshedpur, leaving behind a host of successful people who work not only for themselves but for the betterment of the society. Rabindranath Datta Memorial Award competition is initiated by his son, our past president, Professor Ratindranath Datta, from the year 2016 as a token of honor to this great soul. So this time, the Arun Datta oration is being conferred to Dr. Bernard Cambier. So I request Dr. Bernard Cambier to kindly come onto the stage and deliver his oration.
Thank you.
Okay. Thank you very much for inviting me at the Congress, and thank you for this opportunity to give this lecture. And you know, I'm very sensitive. Thank you very much for everybody here. So, what I learned today is that with the oration that we heard before, is that life is going, and to see the future, we have to look to the past. Because the past can learn us a lot, and that's why I wanted to give a lecture about aesthetic medicine. When I started the lecture, I didn't know something, that I would land here. Because when I was making the lecture, I didn't know that everything started here in India. Everything. And so we knew nothing. We knew a lot about the Egyptians that used animal oil, salt and alabaster and soy milk for skin improvement. And we know what is the name beautiful and to be attractive, because that is clarity, symmetry, harmony and vivid color of a person. But it's more than that. There is also a self-perception, and we want also a very good quality of life. And we know that it's a booming market. And so you can find everywhere aesthetic treatments, and you know that in between 1997 and 2011, in 10 years' time, there was a doubling of the number of procedures. And what is also important, that more and more the surgical procedures are non-surgical, so that we have 83% of non-surgical procedure, non-invasive procedures. And that makes it interesting, because there is a lot of interactions of different disciplines to give this awareness or to make this. You know, yes, you say always, where the most aesthetic procedures are done. And you know where? It was Brazil, you think. No, India is one of the most, the third one. Because in India, you see, you are on the bottom there. But when you see the numbers, you are nearly the top 3 number of aesthetic procedures. I didn't know. But okay, the population is so large here, but the number of procedures are very important. And here again, most of them can be minimal invasive procedures. And I said, okay, nice. But we have a very long tradition, we thought, in the West. No, you have the long tradition. More than 2,000 years ago, it started already with the forehead flap in the reconstruction of the nose. And we know that, or we didn't know, I didn't know, but we see that aesthetic medicine was born here in India. And the first procedures were done here. And this method of a nasal flap is still used with the forehead flap. So nothing changed. We only have to look to the past and to see what's important. And what was the big difference between the West and India? Here you have the Sushra Samhita, excuse me for the name, but there is something important, is knowledge. And knowledge, what is said is that you need to learn. You need to learn also the corpse, you need to learn the skin. And you only can correct the anatomy if you know it. And that makes it a big difference. And you see that in the sutra, there is already a lot of elements that we didn't know even. So the preliminary surgical measurements, the surgical appliance, the surgical instruments, and at that time you had already a panoply of surgical instruments where we had nothing. And so that's incredible. And so the ancient India already practice aesthetics until the late 18th century. And it's incredible, or not incredible, but yes, there were the British here. And when in the Gentleman magazine in 1794, there was the Gentleman's magazine, who said, reported the practice of the first rhinoplasty, like it was in the Sushruta. So, okay. Okay, yeah. So, and here in Europe there was nothing happened, and so that's important because in the Middle Ages, so we call it also the Dark Ages, and there was nothing happening about the development of medicine and even not about surgery. And so many researchers, and that's important, is that they blame the Catholic Church because they wanted that it was godless to choose or to have a human corpse touched. So the Church has banned completely every autopsy or every research on the corpse to know what happens in the future. So we have to wait until the 1430 to know that in Italy there was also a new method to make a nasal reconstruction by using the forearm and bend it for 3 weeks like that, and you could reconstruct the lip and other methods. That was the Italian method, but the Italian method is nothing compared to the Indian method, because this is old-fashioned. And so the first rhinoplasty was first mentioned, the term, in the literature was mentioned in modern literature, not in the old literature, in 1845, and it was by Diefenbach. And so now, actually, from Diefenbach, where he was really more invasive, we are moving now to the medical rhinoplasty, where we are using the products, we are using fillers to have done a correction done. So we are moving from more invasive to less invasive. And at the beginning, the rhinoplasty, the idea of doing a non-invasive rhinoplasty, like you see on the right side of the slide, Diefenbach made already one of the designs of the cannulas to make a medical rhinoplasty, but he could not proceed because he had no products, or what we should see, what will happen, it was not so nice. So we move further. In 1871, the phenol was discovered, and the first phenol peeling was done by Fox. And then later on, they discovered the salicylic acid, resorcinol phenol, and the TCA. So very old techniques, but okay, we are still using them. So after so many years, we are still using them, and we had lecture about all these. So now we see that there are new carriers, and that our formulas are evolving to more modern applications. But okay, already it existed. The first autoplasty was said to be in 1881. No, it's not correct, because in the it was already mentioned. So it was already mentioned. But okay, the operation was described by Diefenbach again in 1845, where he could already put his cartilage or reform his cartilage and to give a good projection of the airway. Actually, we are still moving to a non-invasive system by putting a clip on the 5 minutes lunchtime procedure, by putting a clip on the airway. This technique was very good, but now we are looking for the complication of this, because now we see migration of this new instrument or this device after 3, 4, or 5 years, and we have to explant them. It's not always because we are evolving and we have new materials that these materials will be the good ones. So we have always to look to the past to see the future. Because this is logic that it works, but it's also logic that it not works, because we had a lot of problems with fillers, and fillers were even not solid. So the first rhinoplasty then
was in 1887 and was done by Roux. And what is important, that the instruments were the instruments of Joseph. And still, I'm using one of these instruments. I'm using the elevator of Joseph, so the person who did the first rhinoplasty. Then we are moving a little further, and now we are using nanofat, we are using lip lipofilling. Is it new? No, it's not new. It was already in 1893 that it was done. Already that was the first use of the fat injection. And so here he wanted to use a part of the upper arm to put in the face. And it's only by Illouz and by Coleman that this old technique was again remodeled or reintroduced with success. And here at the end of the 19th century, you see that Vincent Snezny, he was the first person who transplanted the lipoma from the back of a patient who had a lipoma and to correct a breast defect. And so he first removed the adenoma and went then to correct it. So what's very important in the surgery was also the invention of the cannula. And the cannula was invented, or the needle, in 1844. And just after, an Austrian, Robert Gershwin, he had the idea to inject paraffin. Paraffin would be the best filler of the world, and most famous persons, even the second wife of Churchill, the ninth Duke of Marlborough, used it, and she ended up with a very big malformation. And you see, actually, you see that granulomas still have to be removed of that period, not anymore, but well, we see a lot of the granulomas with like Dermalife or with solid particles that are non-resorbable. So we ended up already with the first complication, introducing of a new product, and still after a big complication. And you see, I will show you in the following years that we learned nothing because we still end up with complications. It was in 1907 that there was the first cosmetic eyelid surgery was done. And you see the result. If I had this result, I think I have a lawsuit. Because you see that you have an ectropion, you have a positive sign of von Graf, so that there is a complete ectropion. Okay, is there a laser on it? You see the positive sign of ectropion here also. There is no suspension, but okay, he did it. He did it. Was it a big success? No, it was not a big success, but was the first person who could do it, who wanted to do it. The first facelift was done by Eugène Hollander in 1912, and you will see that his idea of facelift, he will have the traction put in a certain direction. Now we are moving to a non-invasive, by my colleagues from Ghent, Tonar and Verpalen, with the threads and with the small loops that we are placing. But okay, now we are moving even to the threads, like we saw in the previous lectures. But in his idea, this was the same, because he was using also, he removed some parts of skin, but he used the same traction lines that we are using in the modern thread lift. Nothing changed, but our materials changed a little. And here Suzanne Noël was one of the first French surgeons, and she emphasized already that it was very important to take pre- and post-operative photographs. Like today, we have to take photographs to be sure what the patient wants and to be sure how the patients evolve when we are doing something. In 1965, it was very interesting because silicone was the best filling agent. We had a paraffin, and now we moved to the silicone. It was very easy to inject. It was developed by Rees, and it was the perfect filler who will never give any complication. Until 1976, it was used, and until now we have to remove these big granulomas, and so we learned nothing from the past. And you see that some people were really very inventive. They can do enormous edema, and they had big granuloma, or even more, they injected cooking oil under the skin in Korea. There's one case report about injecting cooking oil and had big silicones and also a lot of disfiguration. So the first modern hair transplantation is in 1959, and that was the first one where there was the donor dominance, what's important, and we use what we are still using, but now much smaller, with the Prince graft. They were invented at that time. And then we moved to more technology. More technology because we saw that the lasers came in dermatology. And it was Leon Goldman who said, who used first the tattoo laser with a rubber laser. But it was not a success because he ended up with a lot of hypertrophic scarring and pigment alteration or depigmentation. And the next move in the laser was the CO2 laser, and it was at the time of my birthday, it was by Patel that he was developing it with Bell Labs in the USA. And then they discovered the tissue interaction with laser light, and that light and water, there was a water absorption. And you see the first application was to remove, they see that there was possibility of photothermolysis and that there was possibility of vaporization because there was a high absorption. And the first application was only to remove the navy. It was not a big success because they ended up with a hypertrophic scar. Then we moved from 64 for lasers to the 1980, where the first CO2 lasers resurfacing appeared, and they saw that it was presented as the magic procedure, but rapidly, and we saw in Belgium also a lot of short and long-term effects, because we saw that there was eruption of acne seen in 84%, but also there was a hyper and hypopigmentation problems at that time. We are going to the 70s again and the 80s, and there at that moment there was also a German surgeon, maxillofacial surgeon, here Joseph Schrude in 72, who said it, that he used for the first time a uterine cannula and to remove fat subcutaneously. Here again, it was not a success because there was prolonged drainage, there was hematoma, skin necrosis, but okay, he did it, and that was the first real development with the liposuction and to the liposuction. And I think the most important thing that changed everything is the tumescent technique and the Klein solution. Because from there on, we could have facilitated extraction of the fat, and we also had a blunt in dissection and infiltration, or the blunt suction. And that changed a lot because this tumescent Klein solution, we are using it for other applications. Even in the facelift, I'm using this Klein solution because you have a very good control of your bleeding. And then what's important is that this idea of tumescency, like you see here, was presented in the plastic reconstructive surgery, and it was not accepted because nobody could say it's not possible, and they had to give you a new knowledge and extended patient trial to know if this will work. And so, firstly, they did not accept it, the methods as we know it actually. Then, in the liposuction, it was a crazy period because we had a method, and then we want to use the ultrasound-assisted liposuction. Sochi, an Italian guy, a very nice guy, but there was a problem, is that the ultrasound tip was very well giving a very good lesions of the fat. But the complete cannula involved also gives a lot of energy. And so we had problems with then a lot of hematomas, with a lot of necrosis and a lot of fat cysts or lipid cysts because it was too warm. And so it came very fast, but it was also withdrawal very fast. Again here, there was the energy, the industry push was to use this machine because you had better skin retraction and so on, without really have a good backup. Now more and more we are using the laser-assisted liposuction because then we have no problems with this heat development. And you see here that the problem was that the cannula was not isolated and you ended up with big cysts and with big holes, with sagging and really an uniform platform. Then in the 80s, that was a very big advancement because there was the theory of the selective photothermolysis. Before, with the CO2 laser, they only thought about water, then they were asked about the pigment. And so then we could really precisely target the tissue and select the wavelength to have the tissue or the cell targeted. And so that was a big evolution in the laser, that we could have different lasers for tattoo, for pigmental, and so on and so on. Then, okay, we had the problem of the silicone, of the feathers. Then they thought in USA, we will use bovine cartilage, collagen. And with a test, we had to do a skin test, and some patients were very happy with the feather, others had no good results and ended up again with granulomas. And so collagen was used for more than 20 years, and you see that they were big granulomas post after, and they could be for a long time. And also there the permanent fellows like artificial were used, and here also you ended up with big granulomas because there was a migration of the particles. We had to wait until 92 to use the Botox or the botulinum toxin for cosmetic surgery or cosmetic purposes. It was already used in the ophthalmology and in the neurology, but it had to be used in 2002. Yeah. Faster. Yeah. Yeah, okay. So there was a risk of antibodies, okay? And then the important thing is that we have the hyaluronic acid is coming in 1980. So it's really a long time after that we need the hyaluronic acids given. And then the next big step is the using of the lasers, because before we ended up in laser resurfacing with such devices, and we had a lot of complications of hypertrophic scars, and then we ended up with the fractional system, and that makes a very big point of advancement in the laser surgery, because we are moving from a complete ablation to fractional, and then even to a non-ablative system. So we end up really with very nice results, and also in scarring we have very nice results to correct hypertrophic. Then we have the phosphatocholines who are coming. Was interesting, but was not used in the right way, and ended up with in the periorbital region with a lot of complications of diplopy. And now it's still used for the hip and on the other parts. Then very important also is the cryotherapy, and the cryotherapy ended up with, you will see that there's a big part who has nearly no improvement, and some have a good improvement. But here also the industry is giving us thinking that it's better, but sometimes you ended up with paradoxal lipoma and also pain problems. So the big evolution is also the calcium hydroxyapatite, who will give you the radius was a big part of very good evolution. And then we have the haifus that are good and not good because it's time consuming. And I think that the companies had a very good earning into these machines. So what is the next, or what will be the future, is that we are using more and more stem cells, that we will have more and more possibility to have a better healing and to age less rapidly. But again here, be careful for the future and look to the past. I thank you for your attention. It was a little long. Thank you very much. Okay, very first.
Request Dr. K. Lokendra sir and Dr. Aryan Datta sir to kindly felicitate Dr. Bernard Temple.
Giving out of bananas and
A. Lokendra is a very old friend of mine. He is from Manipur, and if you get down, alight from the plane and ask anybody, I want to go to K. Lokendra's place, and they'll tell you where he is. He's so famous there in Manipur.
So we are at the end of the scientific program. Now we'll proceed with inauguration.
I've taken a photograph of all I need to. Thank you very much. Thank you.
कैमरा निकालना समझे ना फिर बस कैमरा निकाल
Very warm good evening. So we'll go ahead with our inaugural session. So I would like to invite our honorary dignitaries onto the dais. First and foremost, I'd like to invite the Director, Institute of Medical Sciences, BHU University, Professor Satyanarayan Sankwar, onto the dais. Next, I would like to invite Professor K.G. Singh to please come on to the dais. The first MD dermatologist in independent India, Professor Gurmohan Singh sir, please do come on to the dais. Aesthetic Asia Chairperson, Professor Ratindranath Datta sir. Our Scientific Committee Chairperson, Professor C.S. Sarka. Organizing Secretary, Dr. Abhishek Jha. Scientific Secretary, Dr. Shwetlina Pradhan. Regional Organizing Secretary, Professor S.K. Singh.
Hello.
First, we have the welcome address by Professor Ratindranath Datta sir.
Not coordinated. Yeah, tell me. Yeah. So, how can I help you? Tell me.
I'm supposed to give a welcome address. I don't know what to say. All are welcome in this session. And for today and tomorrow, please come and enter the session. And I pay my respect to the director, IMS BHU. My respect to Professor Gurmohan Singh. He's a living legend, the first MD of independent India. And he's the only person he's alive in that batch.
Going on.
So he has become a legend. Then
actually,
we have a friend of mine,
I am auditorium.
Professor K.G. Singh. He was the past HOD of dermatology of BHU. And then there is Professor S.K. Singh, who is the present HOD of BHU. So there are three HOD of BHU: Gurmohan Singh Saab, K.G. Singh Saab, and S.K. Singh Saab. And we have our team over here. So all are welcome. Thank you very much.
We welcome all the dignitaries onto the stage by Requesting Dr. P.K. Roy sir also to please join the dignitaries onto the dais. And Dr. Dinesh Mathur sir, please do join.
दिनेश का बगैर अधूरा लगेगा।
अरे नहीं कोई उधर भी तो बैठेगा।
Any auspicious occasion is started by the inauguration, or any inaugural function is started by lighting of the lamp. I hereby request our chief first garland. Okay, we first garland Dr. Madan Mohan Malviya sir's wife, Dr. Gulmohan Singh, and
Bunty, malata de.
now we'll have the lighting of the lamp by our chief guest. All our dignitaries.
साइड से मैम साइड से
राजधानी नए नहीं है ये ईंट पत्थर है विश्वकर्मा का कार्य सुंदर रचे यहाँ की है ये पवित्र शिक्षा, ये सत्य पहले फिर अपरक्षा, बिके हरिश्चंद्र थे यहीं पर ये सत्य शिक्षा।
Thank you, sir.
Request our chief guest to please address the august gathering.
Thank you so much. Very good evening to everyone present over here. On the occasion of the Aesthetica Asia conference, the dignitaries on the dais, our senior teachers of Teacher Gurmohan Singh sir, Dinesh ji, Rai Sahab, Dr. K.G. Singh sir, Dr. Sweta ji, Dr. S.K. Singh sahab, and audience in this auditorium, guests from the abroad, Belgium and other countries, and my dear student, media persons, I heartily welcome you all here. As you know, the aesthetic is very important nowadays, and everybody want to look beautiful or handsome, and the skin department is doing very good job everywhere. And you know, for the looking good, people are applying many things, and something wrong happens, then only the dermatologist and who are the specialists, they can only solve the problem. Many beauty clinics are there, and they are doing something which create a lot of problem. So Aesthetica Asia conference, I think this will enrich the knowledge of everyone, and with enrichment of this knowledge, everybody will be benefited. So I hope this will be very beneficial for the everyone. I extend my best wishes for the successful celebration of this conference. Thank you very much. Jai Hind.
Thank you, sir. Requesting Gurmohan Singh, Professor Gurmohan Singh, sir, to please few words.
Friends, colleagues, I'm very happy to be one of you on this in this event. I'm invited to be part of this event, which I'm sure everyone will enjoy. I'm going through the program. You will see that the program is excellent and a great mixture. Though it's of aesthetics, but aesthetics dermatology includes general dermatology. It has a mixture of, very nice mixture of aesthetics, surgical aspects, and even the indigenous dermatology. I just telling you something about the indigenous dermatology and this institution. And I was very happy to see one of the articles on which 50 years ago I had done some work here. I came here in 1963. I joined there. I was a lecturer in Amritsar and then joined here. And at that time, there was interest that one could work along with the Ayurvedic medicine and indigenous medicine workers. So I saw one thing. I tried to learn, know, have friendship with the faculty of Ayurveda and learn something. One thing I noticed was haldi was prescribed. My wife had some chest problem. They said haldi, it worked. There's very many diseases. And then going through it, found that it's a good anti-inflammatory drug. I thought that why not to try it on the skin conditions. So it's a very difficult and a long process, and I thought I will do it an experiment on human beings. I had developed at that time a model for the bioassay of topical steroids using the histamine suppression test. So I thought I will use this. I used that haldi solution, different strengths, and compared it with the placebo. I would say water because initially I didn't know. I compared on the two sides of the forearms. This was a model that I had to say topical steroids, anti-inflammatory properties. I thought that it will also be an anti-inflammatory. So I found that there's a definitely anti-inflammatory effect. There was a suppression of the wheals. That the test was very well published and used. It was published in British Journal of Dermatology long ago. I used that test, but then it had no value because it was not a blind. On one hand, it was a colored yellow, and the other side, I have to, because the observer will know that this is a histamine, and there's always, as you know, there's an infection, there's a while. So then I tried other methods, trying to use a color, similar color, and not knowing. But anyway, with all those experiments possible at that time, I found it anti-inflammatory, and I found Dr. Datta, that's the program in today that he has shown again and give us the history. And I think we can use many of other anti-inflammatory drugs. I must congratulate for Dr. Datta for bringing in, again, introducing this indigenous medicine in the modern room. And now I wish, this is for, we are formally inaugurating this conference, and I wish it all success. Thank you very much.
Thank you so much, sir, for those inspirational words. Next, we will have the release of souvenir by Professor K.G. Singh. We now request Professor Gurmohan Singh, sir, to please release our journal.
This is the first issue of this international journal called Aesthetics International. We are trying for the last 5 years to publish it, but after a long time and a lot of work, we could succeed. This is published by an international organization called Waterprover. They are the publishers. They have many journals which they publish. And I request you all to send articles for this.
Now requesting Professor Arandatta sir to please present mementos to our chief guest and other guests of honor.
I request Lukendra to come up also. you present this to all your Thank you so much. Thank you so much. Now, I can present it. Set.
Requesting sir to please present the memento to Professor Gurmohan Singh sir. Requesting Professor Arundhata sir to felicitate senior dermatologists of UP. Presenting the guest of honor to Professor S.K. Singh, Head of the Department, Dermatology Department, PhD. I now request our chief guest to please honor the organizers. Aesthetic Asia Chairperson, Professor Ratindranath Datta sir. Scientific Committee Chairperson, Professor C.S. Sarka sir. Scientific Secretary, Dr. Shwetlina Pradhan.
हेलो
लो भैया साइड हो जाओ, साइड हो जाओ भैया।
अभी तो हमारे पास है, हम भी 5-10 मिनट में
नहीं, यूपी का डॉक्टर को फेलिसिटेट करना है, वो बोला है, उसको लिखा है, कम ही है ये है
আপনি লাঞ্চের সময় কোথায় ছিলেন? লাঞ্চের সময় কোথায় ছিলেন দেখলাম না তো।
আমি ছিলাম না, বাইরে গেলাম। লোকেন্দ্র ছিলে ওর সাথে বাইরে কোনো একটা জিনিস কিনে
ওহো
Requesting Arindata sir to please felicitate the senior dermatologist of UP, Professor Gurmohan Singh sir, Professor KG Singh sir, Dr. Sanjay Singh,
साइड
Dr. Vinod Kumar Singh. I request Arindata sir to give a token of gratitude to the conference partner, MSN Labs. Requesting MSN Labs to please over to the dais. Torrent Pharma. JRK Labs,
GRK,
Omni Life Sciences, Cosmofix.
अरे अभी आ जाइए तारीख साहब बड़ा छिपा हुआ है छिपा रुस्तम अभी आ जाओ
Petro Life Sciences, Gap Pharma, I now request the head of the Department of Dermatology, IMS BHU, and the Regional Organizing Secretary, Professor Dr. S.K. Singh sir, to please deliver the vote of thanks.
Respected and our most distinguished chief guest of the day, Director IMS BSU, Professor S.L. Sankwar sir, respected Guru Mohan Singh sir, guest of honor Professor K.G. Singh, and my dear friends. It is a great honor to propose the vote of thanks to all who helped us in making this conference such a resounding success. First of all, I would like to propose heartily vote of thanks to our Director, Chief Guest, Professor S.L. Sankwar sir, for gracing today in the conference. In spite of his very busy schedule and hectic schedule, he is kind enough to accept our request to join the inaugural session. Professor Guru Mohan Singh sir, a great teacher, in fact, teacher of our teacher. Thank you, sir, for blessing the occasion and very interesting and thoughtful provoking address. I would like to thank our respected speakers, Professor Dilip, Dr. Monish Paul, Professor Niti, Dr. Manas, Dr. Maithu, Dr. Srivas, Dr. Swatlina, and all other speakers for making excellent presentations and making the conference interesting and meaningful. I express our profound gratitude to all the panelists and chairperson for their fruitful discussion in this conference. I am happy to express vote of thanks to the team of Professor Datta for their sincere efforts in making this event smooth and easy. Thank you so much, sir. I would also like to thank the coordinators of all the events for making this conference a great success. We are also grateful to all the sponsoring organizations and finally the wonderful delegates and the students who have turned up in great numbers. Thank you so much for your cooperation. Once again, I thank all of you for cordial cooperation. Thank you.
One small function is left, and that whatever we could do today is because of the Department of Dermatology. So we would like to present a memento to the Department of Dermatology, BHU IMS. And I request all the past HODs and our chief guest to come up over here and receive the memento. Gurmohan Singh sir, please. All the HODs of this department, please come. Thank you, thank you. So we conclude the session here. We are meeting around 7:30 at Ramada for the gala dinner, and tomorrow we'll try to start at 9:30. That is the award paper session and short paper session.